Excellencies, distinguished guests, ladies and gentlemen, welcome to the 2024 HIRA International Symposium.
Ladies and gentlemen, good morning and welcome to the 2024 HIRA International Symposium. Before we begin today's event, please allow me to introduce myself. My name is Jessica Seung-hee Lee, and today I've given the honor of being your host at this very meaningful and wonderful event. 여러분 인사드리겠습니다.
It is my great honor and pleasure to announce you today. My name is Jessica Seung-hee Lee, your MC for today's event. Thank you so much for being here at such an early hour. We appreciate you taking the time out of your busy schedules to be here and make this event very special. Also, this symposium is being broadcast live on the official website as well as HIRA's official YouTube channel. We'd also like to extend our sincere thanks to those who are joining us online. Before we begin, please note that we do provide simultaneous interpretation in Korean and English, Korean Channel 2 and English Channel 3. Please select your language of choice.
For your information, please note that we do have simultaneous interpretation service throughout the session today. Channel 2 is for Korean, and Channel 3 will be in English. So please select your language of choice. Thank you. 여러분,
To practice carbon neutrality, we have used mostly eco-friendly materials for this symposium. And to reduce paper usage, we didn't print paper booklets. For those of you here in person, you can download the symposium materials by scanning the QR code on the screen. Also, we encourage you to participate in our satisfaction survey, which you can access from the same QR code. So the QR code is on the screen and also on your name badge. For our YouTube viewers, please check the link below the video to access the materials and the survey. Every year, the Health Insurance Review and Assessment Service, HIRA, hosts this international symposium to share insights on health insurance systems and healthcare issues from around the world and to explore future directions for progress. This year's symposium is particularly meaningful as it marks the 20th anniversary since we first started this event back in 2005. Over the past 20 years, the symposium has kept pace with the development of Korea's healthcare systems, and HIRA, by focusing on key topics such as DRG payment systems, healthcare quality assessment, new medical technologies, and DUR, we've prepared a short video to take a look back at the history and milestones of HIRA's International Symposium. Let's watch it together.
네, 여러분 큰 박수로 축하해 주시면
A big round of applause, everyone, please. Thank you. We hope you enjoyed that special moment as we reflected on the past 20 years of this international symposium and recognize the contributions of healthcare experts from around the world as well as the dedicated staff of HIRA. Thank you very much, everyone. One more quick note. The historic moments captured in the video have also been displayed on the history wall, which we have set up in the lobby area just behind the event hall. Please feel free to take a look during the break. Now, let's bring our focus back to the present and continue the story right here, right now. As you saw in the video, this year's 2024 Symposium is centered around the theme of evaluating the outcomes of high-cost drugs using real-world data. We've designed a program to discuss real-world examples and outcomes of RWD usage, share experiences and challenges, and delve into the governance of RWD. So without further ado, let's officially kick off the 2024 HIRA International Symposium. I look forward to many insights being shared today. To begin our program, we will have an opening address that will set the stage for the symposium. Please welcome Dr. Kang President of HIRA, to deliver the opening remarks outlining the purpose of this symposium. A big round of applause, everyone, please.
Review and Assessment Service.
안녕하십니까?
Ladies and gentlemen, I'm Kang, President of HIRA. It's a great honor to welcome you all to the 2024 HIRA International Symposium. I'm deeply grateful for your interest and support which have made this significant event possible. I would also like to express my sincere appreciation to the distinguished healthcare experts from both Korea and abroad who have joined us today, despite their demanding schedules. We're particularly privileged to have with us today several renowned international speakers: Dr. Bor-Sheng from the National Taiwan University Cancer Center, Dr. Jatin Dave, and Dr. Neha Karshalikar from the UMass Chan Medical School in the US, and Dr. Klaus Moldra from the Danish Medicines Agency. Thank you for traveling afar to join us today. Additionally, though unable to join us in person, Dr. Vandana Ayyar Gupta from NICE in the UK and Dr. Nicole Mittman from CATH are participating with us online. I would also like to extend my gratitude to our esteemed chairs, Chairman Yoon-Soo Park and Chairman Jung-Shin Lee, as well as all the panel members for their contributions to this event. The theme of this year's symposium is performance evaluation of high-cost drugs based on real-world data. As high-cost innovative health technologies are increasingly deployed, it is essential that we assess their clinical and economic impact in real-world settings. This is a critical challenge for the ongoing development of our health insurance systems. At HIRA, we have consistently sought to enhance our pricing and reimbursement frameworks through evidence-based decision-making. In particular, we are focusing on the application of real-world data and shaping policies and systems related to high-cost drugs. Real-world data allows us to move beyond the confines of clinical trials, enabling more realistic and practical evaluations. This approach not only strengthens the rational and effective management of health insurance systems, but also elevates the quality of care delivered. Today, we are very fortunate to have experts from Diverse nations will share their experiences, achievements, and the challenges they have encountered in leveraging RWD for evaluating high-cost drugs and technologies. I'm confident that these discussions will pave the way for further advancements in our healthcare systems. Moreover, I hope this symposium will serve as a catalyst for deepening collaboration among global healthcare institutions, research entities, and industry partners as we exchange innovative ideas to positively impact clinical practice. I trust that today's symposium will be a significant milestone in our collective efforts to advancing and innovating within the healthcare field, and I hope that each of you finds this gathering to be both enriching and inspiring. Thank you very much.
원장님 개회사
Thank you so much for the insightful remarks, President Kang. He touched upon the purpose of the symposium, and he also highlighted his commitment to the advancement of health insurance systems. Thank you so much.
이제 본격적인 논의에
So before we begin the symposium, we will first take a commemorative photo. We will only take one round of photo, and we would like to invite our distinguished guests up to the podium. So today we will hear the keynote speeches, session 1 and session 2. In the afternoon session, we will also have a panel discussion. So I believe that today's symposium will be all the more insightful. So I think we are ready to invite our guests up onto the stage. Mr. Kang Jung-ho, the president of HIRA, please step up to the stage.
distinguished guests and our panelists, our speakers and moderators, please come up to the stage. 네, 이어서 심사평가원 임원진 여러분.
And also, we would like to ask the management of HIRA as well as our honorable speakers and panels to please come up to the stage. We have a lot of people here on site, so we will have 2 rows when taking the photo. Make sure that your face can be seen.
Have a one round of photo shoot today, and please make sure that you're standing in between people in front of you. Please make sure that your face is well shown to the camera. 자, 카메라에 잘 보일 수 있도록 서 주시기를 부탁을 드리겠습니다. 네, 저희 운영요원의 안내에 따라서 좀 도열을 해주시고요.
Okay, we will stand in 2 rows. Please make sure that the camera can capture your face. We are commemorating the 20th anniversary of 2024 HIRA International Symposium. This is the very last order of proceedings for our opening ceremony.
보이도록 도열을 도와주시면 좋을 것 같습니다. 네, 좀 붙어서 서주셔도 좋을 것 같아요. 자, 앞쪽 저희는 중앙 카메라를 보셔야 합니다.
Please look into the camera at the center. We will take a photo now.
Smile towards camera. 중앙에 있는 카메라 봐주시고요. 네, 한 장 더 찍겠습니다.
We'll take one more photo.
Stage, we will have one more shoot. Look at the camera, please. 네, 활짝 웃어주시죠. 네, 활짝 웃어주시고요. 자, 여러분 저 20년 앞으로 더 인사드릴 수 있도록
Please hold your hand up, one hand up, and say fighting.
in Korea. Thank you. Look at the camera. Maintain your pose. 네, 하나, 둘, 셋. 화이팅! 네, 앞쪽 카메라 봐주시고요. 잠시만 기다려주시죠. 네, 고맙습니다. 자리로
Thank you very much. Please return to your seats.
May return to your seats. Thank you. 네, 고맙습니다.
Thank you very much. So as I mentioned, we are commemorating the 20th anniversary of HIRA International Symposium, and I hope that for the next 20 more years, we will be able to greet you every year.
적으로 저희
Now we'll officially begin the main program. A big round of applause, everyone. Thank you. Thank you so much, Dr. Gupta, for sharing the presentation via recording. Next, we have the next keynote presentation.
인데요. 한국 건
We will hear from So-Young Lee, the Director General of Pharmaceutical Performance Assessment, Department of HIRA. She has been with HIRA for over 21 years now, with prior experience in the Pharmaceutical Management Department and Korea Pharmaceutical Information Service of HIRA.
그럼 RW
So she will be presenting on the RWD-Driven collaboration for sustainable access to high-cost medicine. Please welcome her with a big round of applause.
Young Lee, Director General of HIRA, please come up to the stage.
이렇게 귀한
I'm honored to give a keynote speech at this honorable event. So because I'm the keynote speaker, I'm going to be giving an overall picture of the current situation so that we can follow up with presentations from different countries, speakers from different countries. So today I'd like to talk about a very important issue that's facing us. Right now, a lot of people are pained by diseases and high-cost medicine. We want to be free from these diseases and to live a healthy and long life, which is why we continue to see innovations in pharmaceuticals. But the thing is, these pharmaceuticals are very high cost and are difficult to access. So this is the critical problem that we are facing right now. That is why RWD-driven collaboration is becoming all the more important, and that is going to be the topic for my speech today. So first, let's look at the status quo. Where are we now exactly? So for those first slides, let's go to 2016. In the Sustainable Development Goals 2030 Agenda of UN, if we look at the healthcare sector, I'm not sure if you can see what's printed out here in the slide. It's quite small, but it says that we need to make sure that everyone can have access to healthcare. And for that, efforts to increase accessibility to pharmaceuticals is very important, and that is why this report of the UN Secretary General's high-level panel on access to medicines was published. In the report, it stated the importance of transparency, and we can see here that it's important to research new mechanisms to divide the R&D cost and the list price, so the end prices. For this, publicly funded research is very important. Publicly available clinical trial registry platform is very important, as well as the others listed here. And in 2019, the 72nd WHA resolution on improving the transparency of market for medicines was held. Now, this was at the brink of the COVID-19 pandemic, which is why this approach was dealt as a very important agenda for vaccines and medicine. And more than anything, the availability of comparable price information was dealt with as a very important topic. And the resolution urged member states to improve transparency on net prices, as well as supplier information, clinical trial results, and costs. So not only successful clinical trial results, but also unsuccessful clinical trial results, as well as its cost, some patent status, and marketing approval status. And after the WHA resolution, some strategies were also set forth to concretely go ahead with the resolution. Also, the biennial WHO Fair Pricing Forum was held from 2017. So what is the current situation now? Why is this international organization urging member states and coming up with such important agenda. We need more collaboration going forward. So this is data from IKEA. So you can see the list price as well as other agendas here. Right now it's 2024, and you see how the list prices are going to change from 2024 to 2028. You can see that it's listed in 5 percentages. Therefore, you can see that the list price will not increase by a lot. But when it comes to medicine prices, you can see that in 4 years, in Europe it will go up by 30%, and in America it will go up by 40%. Basically, we call this the mix effect, how the prices of medicine go up by a lot. Low-priced drugs are now going to be high-priced drugs, and some medications are going to be replaced by new medications in the market. And this is on a trend of a specific region. You can see that all across the globe, we will see a high increase in medicine prices. So then what is the current list price like for prescription drugs in the US?
2017년부터
It shows from 2017. There was a time when it was $160, but the price in 2022 to 2023 is on average $589, which is a very high increase. And on the bottom, you can see that it is a lobe scale. This shows how the price has quadrupled in a very short amount of time. And it makes you wonder, how is this possible? Some of it is due to inflation. And here we need to also look at the increase rate in prices. I think I'll be able to explain why the increase has been so significant. We see the increase rate about 20%. And the thing is, because the average price right now is so high, even a 1% or 2% increase leads to significant actual amount increases. So you might think that because the average increase rate is low, the prices aren't that high. But the thing is, you have to think about the fact that the base price is high to begin with. So that's what you should consider. And you can see that in 4 years from now, if we see additional 30 to 40% list price increases, that will be even more significant in the actual amount. So now let's look at the prices for newly marketed drugs from 2008 to 2021. It's regarding newly marketed drugs within this timeline. You can see that the median number increased by 85 times. And here in the picture, you can see that they even excluded 6 drugs over $1 million per year. Now let's look at the situation for Korea. You can see these bars, and you can't even see these bars in detail because high-priced drugs have become the norm when it comes to newly marketed drugs. If we don't adjust the scale, we can't actually see the status quo in detail. So on the left, you see about 100 million to 200 million. And here you see the trend and how there are so many outliers, so high-cost drugs. The overall trend looks like it's heading upwards. And in 2017, you can see that there were a lot of outliers, but overall the trend is that the newly marketed drugs are very high-priced. So let's look at the classes of these high-cost drugs. So when we look at the national health insurance, The upper cap is about 94 million for the highest paying citizen in Korea. Here, anti-cancer drug take up 24%, and the rest is rare disease treatment, which is something that's very much expected actually. So the number of anti-cancer drugs as well as the ratio of anti-cancer drugs is the highest. So then, let's look at the life cycle of these drugs. The blue here, the blue to the purple are the ones that still have patents, protected patents. And you can see that they are increasing very much, especially the blue. And you don't see a lot of the orange, which are genetic drugs. This is something that's expected. If we see effective drugs in the market, it's natural that they're used to treat patients. And also for manufacturers, it's important to make good use of patents before the period ends. Which is why the period after a drug is listed to the patent period is very important. So basically, all of this process is key to deciding the marketable price and other related factors. And right now, we do value-based pricing in Korea. This means that we determine the effectiveness of medicine to see if that could be reimbursed. As you all well know, very high-priced drugs are very uncertain in their effectiveness because clinical trials on patients cannot be standard clinical trials, which means that there's no comparators and the tracking time might not be enough, and the endpoints could be surrogate endpoints as well, which is why a lot of intervention is needed. Our existing medicines have a lot of uncertainty already, but the thing is that is aggravated for new medicine, which makes the situation even more difficult. And credibility about new medicine is also very low. So these uncertainties may actually lead to prices that are higher than the health system deems affordable. Because this is the case, countries all around the world face different problems. We have new effective medicines in the market, and there's patients in need of these medicine. However, it's difficult to get rid of the uncertainties, which is why MEAs, managed entry agreements, come into play. So let's look more in detail into MEAs. There's two types of MEAs. There's financial-based and performance-based. As you know, financial-based is the more simple, effective agreement. On a patient level and population level, you look at the entire amount and the entire amount and price of the drug that is used, and that is applied for a discount and rebate. Now, for performance-based, you need to collect a lot of data, do a lot of different evaluations, and it's not sure whether you have inherently gotten rid of uncertainties even after all of this process. Performance-based MEAs are used to get rid of problems with financial MEAs. So on the patient level, you can see the budget impact straight away. So for budget impact, it's much better than waiting about 5 years. And also, when we look at the medicine criterias, it can be used for coverage with evidence development as well. So that basically determines on which patients the medicines can be used. And this is effective to collect more data and to assess the performance on a patient level. Korea, as well as a lot of other countries, are also going with performance-based MEAs. So that was what we saw in the OECD. So you can see the cost effectiveness and the budget impact was very superior when it came to performance-based MEAs. But as I mentioned, performance-based MEAs lead to a lot of administrative costs and efforts, which is why we only use this model when there's a lot of benefit over the financial MEA. And also we have to think of whether we can identify uncertainties to act upon the additional evidence generated as a result of MEAs. So now let's look at the drug spending and pharmaceutical policy. This is by IKEA. And it shows the ratio of drug spending. And you see each line representing each country. So you see the very highest yellow line there, that is Korea. In 1977, in Korea, the National Health Insurance Service came about, and after that, list prices have continued to increase significantly. Regarding this, in 2006, we decided to make a decisive judgment, and we implemented the positive list system and conducted pharmacoeconomic tests. So right now, only medicine on the list have cost effectiveness as well as significant benefits for patients. And list prices were decreased at this point in 2006. But as I showed in the previous slide, a lot of high-cost, innovative medicines were released in the market, which led to more problems for HIRA as well as manufacturers and payers. So the assessment period kept on being postponed and lengthened, which led to a lot of social problems as well as problems for patients. This is why we implemented the risk assessment management system then. Now, for rare diseases, when clinical endpoints weren't enough, we decided to go ahead with surrogate endpoints and also exempt some medicine from PE. In 2022, performance-based MEAs were adopted in Korea. So this graph basically shows the policy changes as well as drug spending trends in Korea. The same goes for all around the country. We see that many countries are trying to improve their system, but we see a lot of unclarity, especially in terms of pharmaceutical costs in clinical trials. So transparency is becoming a bigger issue. Accessibility for patients is still low, and sustainability is also low at this stage. So then where do we go from here? We have to, of course, shift our current paradigm, have a lot of discussions, try to decrease the list price. But will these be enough to provide accessible medicine for patients? We now have to just transform the entire paradigm and start with a clean slate. So let's turn back to fair price. It's very conceptual and it sounds like a very difficult term. So WHO's definition of fair price is affordable price for health systems and patients, and price that provides sufficient market incentive for industry to invest in innovation and R&D required to produce new effective medicines. So basically, its definition is a price that is beneficial for all players. And at the heart of this lies transparency. A lot of NGOs have come up with these calculators to calculate fair price, and it includes things like premiums for innovations and R&D costs. So let's see this data from BMJ journal. The line in red is the fair price, and you can see below the fair price is the range for the fair pricing zone, and if it goes above the red line, it's excessive pricing zone. And of course, for each country, there's difference in affordability depending on the payer's situation. So you see high, medium, low affordability. Each country creates prices for their own market, so we need to reference each country's price, and the base price is the same. Basically, the affordability level is different for each country, but the base price is the same for each medicine. So basically, countries with high affordability can afford these drugs, but countries with low affordability cannot afford these prices. So if the low affordability countries can pay for these drugs, then we say that it's a fair price. And for that, we would need to decrease the R&D costs. And on the very right, you can see that the R&D costs aren't even included in the fair price. Now, if we see a graph like that, we can see that the fair pricing zone is included even for low affordability countries. I don't want to talk about whether this logic is right or wrong. I think that it's important to notice how these graphs have just taken into consideration the calculations for fair price. So how can we improve R&D productivity? So in the US, we see that the investments for new drugs is about 10 times it has been in the past. COVID-19 pandemic has been a very big crisis for humanity, but it has also been a great opportunity for humanity at the same time. We have been taking a look into a lot of the data that we have just disregarded in the past with COVID-19 pandemic, and through AI, a lot of technological improvements are coming about. So R&D as well as technological innovation have become the norm after COVID-19. Now, in traditional clinical trials, RWD didn't play a big role. Basically, they were only used to assess which hospitals the clinical trial was held in. But now, we can also get data from wearable devices of patients, and also we can use RWD when there aren't comparators, so we can use external comparators. Overall dependency in RWD can be increased. And this is something in the Nature journal. About 100K medicine have been invented with an excessive amount of investment. So if we utilize R&D in new medicine development, we can drastically decrease R&D cost. And it can be used for IND, NDA, and HTA. So it can be used for all stages of approval. And for this, Europe, Canada, and the US are sharing the real-world evidence that they have. So this isn't just something that's conceptual. You can see that in the US FDA, there's about 10 guidelines already on RWE. And 88 of the newly approved medicine in the US used RWE, and also a lot of clinical trials right now in the US are using RWE. The same goes for AI. In 2023, you can see that 67 medicines that used AI is in phase 3 of clinical trial. And let's go to EU now. They have combined HTA regulation with approval regulation. And going forward, all drugs, even including orphan drugs, will be included in the regulation. And the EU will also cooperate to share these information and evidence with one another within the region. So network within stakeholders is very important. Stakeholders will collaborate with one another, even from the medicine development stage, so that all of the data of the medicine is put together. And after the Ministry of Food and Drug Safety approves, even more data is combined. So in EU, we see data analysis and real-world interrogation network, the Darwin network platform, that they are utilizing for more collaboration. We have more than 25 countries as data sources. You can see the number of inpatients, outpatients, and much more. Even if we look at last year alone, you can see that through data, you can see that through Darwin, a lot of data has already been accumulated. And to 2023, you see about 10 to 20, but from 2024, you can see it increasing to about 50 to 60, and from 2025, that will increase to 100 to 120. Now let's look at HIRA's big data system. We have the national registration numbers of citizens. That's why we are already able to use a lot of real-world data, because we have a lot of medical treatment data already. So with the drug data, medical resources data, and medical treatment data, we can make better use of RWD. From 2013 to 2022, we have signed 60 RSAs, and also a lot of medicine for PE exemption. And by sharing the cost burden through MEA, we have been able to come up with better outcomes for patients. And you can see that right now we have 5 patient-level performance-based reimbursement agreements, so performance-based MEAs. We are lagging behind a lot compared to other countries' examples that I showed you before. And we feel like information asymmetry is very high right now. We only have access to publicly available data right now, and even if we request data, we cannot get them in a lot of the cases. It's very difficult to negotiate with pharmaceutical companies that already have a lot more data than us. And we also have insufficient acknowledgement of uncertainty. And it's difficult to get rid of this uncertainty overall, which is why we want to keep on expanding such risk-sharing agreements. And we have started many platforms to talk about these agreements, but a lot of the discussions were negative. A lot of people have been saying that RWD and RWE are difficult to trust. They are not credible. And managing the reimbursement of RWD is just not feasible, and it's not reasonable. This is what a lot of people have said. If you look at the big picture, I get why people say this, but we need to think about what our purpose is in using RWD and why we're using RWD in the first place. So let's talk about 3 specific cases. The first is Kymriah. We have about 2 years worth of results now for the RWD. And in the Juliet clinical trial, you can see that the ECOG performance status, stage 0 and stage 1 was only used. And that was to control the clinical trial better. And right now, Kymriah is being used to reimburse patients with differing health conditions. So the ECOG level 1 and 2, level 0 and level 1 aren't the only levels included for the reimbursed drug right now. So ECOG performance status is actually a very important variable. And for patients to use Kymriah more effectively, we need to make use of this clinical trial data as well as RWD. So let's look at the clinical trial. This was something that was conducted for about 5 years. You can see that the important endpoint was response rate and overall survival. If you look at the graph, you can see that at a glance, it looks like a very positive outcome. But the thing is, we did not meet our target for response rate, and that was because in the process of tracking, a lot was lost. And for overall survival, we got about 39%, which is a little bit less loss in tracking than the response rate. So in our RWD for overall survival, the tracking should be 100%, and for response rate, it's about 3 to 4%. So then which is the better endpoint for us to utilize? I think you can see the answer here from the graphs. The second example is Spinraza, used for SMA. The clinical trial was used for adolescents. But the thing is, in real life, more than 60% is used on people over the age of 12. So then what does the RWD show us? It shows us results that we cannot get from the clinical trial. And also, through RWC, you can see the age at symptom onset, which is a very big variable, and the disease duration. So you can see that the medicine accessibility increases a lot after a drug is marketed, which is why the age at symptom onset and disease duration is very important. And you can see that the variables that were deemed important in the clinical trial are less important when it comes to RWD. So this is something that was pre-approved by HIRA. And with the pre-approved data, you can see that for children less than 5, when they're treated with this medicine, their activity level increases. This is all that we know from our actual data. And case 3 is regarding TS1. So this was used for 6 weeks, and in clinical trial it was used for 3 weeks. It was a retrospective study that was conducted, and the 6-week TS1 monotherapy regimen for gastric cancer was reimbursable. With more RWD, we think that we can decrease a lot of the uncertainties currently facing us. So basically, RWE can be used in all phases of the drug life cycle, and it can be used to fill the blind spots that we have right now. It can be customizable, and it can give us the result values in a very fast manner. Of course, there are some limitations of RWD as well. And these limitations are also very significant right now. We should make sure to focus on privacy matters of individuals and to increase transparency and independence of RWD. These are the homework that's facing us right now. And we already are seeing a lot of process in terms of operational limitations, technical limitations, as well as other types of limitations. Now let's go to the conclusion. So there's a lot of benefits of using RWD, and through RWD, we will be able to manage reimbursement as well as actual treatment for patients while decreasing the list price. And in health insurance, we will be able to list better medicine and gather evidence for these medicine, revisit our decision making. We need to think about whether we are provider, payer, patient, or manufacturer. This is what the slide shows. Now, in using RWD, unity is critical. You cannot make good use of RWD if you only use your data. You have to collaborate with others, and institutions should hold hands to decrease uncertainty by gathering more data. So basically, this is a win-win strategy. And we can divide RWD providers into government, patients, industry, professionals, healthcare providers, and public sectors who should all collaborate at each stage of the medicine life cycle for transparency, and we should all have accountability. So accountability and risk sharing among all parties is very important. Amidst the technological development that we see all around the world, we need to make sure that good medicine can be provided for patients without undermining the pharmaceutical industry through the usage of RWD. Thank you very much. Thank you very much. Please give her a big round of applause. So Director General So Young-Lee gave the second keynote speech.
지금부터
We'll now break for lunch and take a short rest until 1 p.m. Please keep the interpretation receivers provided earlier and kindly leave them at your seats at the very end of the event. For our distinguished guests who are informed in advance, please follow our event staff to proceed to the lunch venue on the first basement floor. And for the rest of the participants here, lunch boxes will be provided at your seats. We'll see you back here at 1. Thank you.
Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. It fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services, so that it could contribute to enhancing health and social security for the people. Some people say we are quite stubborn and strict. However, there are solid principles that we must stick to, no matter how hard it is. Fairness to save the health and safety of the people. Trust to establish quality healthcare system for everyone. Expertise to accelerate Korea's healthcare system and to take the lead in highly advanced medical environment. and connectivity through consistent cooperation and communication with the people and stakeholders. We will navigate ourselves to the destination we set by the 4 principles, no matter what it is. As we gather years of experiences and know-hows, and as the people and hospitals expect more from us, we naturally push ourselves toward a higher standard. We've never been afraid of taking on challenging risks. Long before the global shift towards digital transformation, we were already harnessing the power of our advanced ICT system to collect healthcare data. This seamlessly interconnected data plays a pivotal role in our daily operations and regenerates new value-added information. This concerted effort contributes significantly to delivering enhanced healthcare services for the benefit of the people. The essence of HIRA is reflected in its commitment to review and assessment. We objectively and fairly evaluate service claims submitted by providers to ensure that they align with our legal criteria and requirements. This ensures that health insurance premiums are maximally utilized for the benefit of the people. Additionally, we assess hospitals to determine if they deliver the most effective medical services from the patient's perspectives. We share these results with the public, contributing to the elevation of healthcare quality. Another responsibility of HIRA involves establishing the benefit criteria covered by the National Health Insurance. We define and monitor the suitability of benefit criteria for both providers and patients by regularly and incrementally updating reimbursable health services. Moreover, we assess whether to list new health products and technologies in the benefit package. This helps ease the financial burden on patients and enhances healthcare accessibility. We enhance the accuracy of claim reviews and quality assessments through Integrated Healthcare Resource Portal. This portal serves as a platform through which hospitals share essential data, including information about human resources, facilities, and equipment. The Drug Utilization Review is a real-time solution that provides doctors and pharmacists with vital drug information during the prescription and dispensing processes to ensure patient safety. This service safeguards the health and safety of individuals by conducting pre-checks on potentially unsafe drugs and ultimately preventing patients from taking such medications. Pharmaceutical Information System plays a pivotal role in patient safety as well. We serve as the command center throughout the entire drug distribution process, spanning from production to supply. This contributes to a transparent and well-managed pharmaceutical distribution system. To predict any possible diseases in the future and revitalize the current medical industry, we are making healthcare big data accessible to academia, medical communities, industries, and the public. As a specialized organization in claim review and quality assessment, we have been actively collaborating with countries around the world in terms of R&D and healthcare projects to create and provide quality healthcare information to the public. We believe that our unwavering and continuous efforts will secure a future of healthcare services for the people. We take full responsibility for public health and safety, thoroughly understanding all aspects by taking the closest look and the deepest dive into them. We offer a range of systems and services, prioritizing people's right to information and valuing them as health service consumers. We provide a service that allows patients to verify whether the health services they received are covered or not. Furthermore, we make non-reimbursable health service items accessible to patients for their informed and reasonable decisions. We require hospitals to clarify uncovered health services to their patients before consultation. We also allow people to easily access to health-related information on their mobile phone. The Medication History Verification Service stands out as a remarkable public service. Through this service, patients can track the medicines they have taken in real time. It operates by utilizing pharmaceutical information collected during the prescription and dispensing process. Drug Information Provision Service is another public service that enables patients to easily check details like expiration dates and warnings by scanning the barcode with their mobile phones. We also offer a top-rated hospital finder service, making it easy for people to find the hospitals they most need, right in their neighborhood. We are promoting and extending various services so that everyone can enjoy more prosperous health services. HIRA has always been with the people, even in an unprecedented national crisis like COVID-19. As a lead healthcare institution, HIRA supported the pandemic response at the entire process with state-of-the-art ICT capacities, advanced human resources, and materials. We also have led by example in promoting the best practices of our quarantine policies and healthcare services that played a significant role in response to the pandemic. In particular, we raised the national status and competitiveness by exporting Korea's healthcare system to Bahrain and providing tailored healthcare policy consultation to many countries. There is a reason that we stick to our principle more stubbornly than anyone else, because we know the potential and power behind the commitment and perseverance to uphold the basics. We believe that today's principles become a driving force of tomorrow. With this belief, we're dedicated to shaping an advanced healthcare environment where everyone can enjoy health and happiness. Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. It fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services, so that it could contribute to enhancing health and social security for the people. Some people say we are quite stubborn and strict. However, there are solid principles that we must stick to, no matter how hard it is. Fairness to save the health and safety of the people. Trust to establish quality healthcare system for everyone. Expertise to accelerate Korea's healthcare system and to take the lead in highly advanced medical environment. And connectivity through consistent cooperation and communication with the people and stakeholders. We will navigate ourselves to the destination we set by the 4 principles, no matter what it is. As we gather years of experiences and know-hows, and as the people and hospitals expect more from us, we naturally push ourselves toward a higher standard. We've never been afraid of taking on challenging risks. Long before the global shift towards digital transformation, we were already harnessing the power of our advanced ICT system to collect healthcare data. This seamlessly interconnected data plays a pivotal role in our daily operations and regenerates new value-added information. This concerted effort contributes significantly to delivering enhanced healthcare services for the benefit of the people. The essence of HIRA is reflected in its commitment to review and assessment. We objectively and fairly evaluate service claims submitted by providers to ensure that they align with our legal criteria and requirements. This ensures that health insurance premiums are maximally utilized for the benefit of the people. Additionally, we assess hospitals to determine if they deliver the most effective medical services from the patient's perspectives. We share these results with the public, contributing to the elevation of healthcare quality. Another responsibility of HIRA involves establishing the benefit criteria covered by the National Health Insurance. We define and monitor the suitability of benefit criteria for both providers and patients by regularly and incrementally updating reimbursable health services. Moreover, we assess whether to list new health products and technologies in the benefit package. This helps ease the financial burden on patients and enhances healthcare accessibility. We enhance the accuracy of claim reviews and quality assessments through Integrated Healthcare Resource Portal. This portal serves as a platform through which hospitals share essential data, including information about human resources, facilities, and equipment. The Drug Utilization Review is a real-time solution that provides doctors and pharmacists with vital drug information during the prescription and dispensing processes to ensure patient safety. This service safeguards the health and safety of individuals by conducting pre-checks on potentially unsafe drugs and ultimately preventing patients from taking such medications. Pharmaceutical Information System plays a pivotal role in patient safety as well. We serve as the command center throughout the entire drug distribution process, spanning from production to supply. This contributes to a transparent and well-managed pharmaceutical distribution system. To predict any possible diseases in the future and revitalize the current medical industry, we are making healthcare big data accessible to academia, medical communities, industries, and the public. As a specialized organization in claim review and quality assessment, we have been actively collaborating with countries around the world in terms of R&D and healthcare projects to create and provide quality healthcare information to the public. We believe that our unwavering and continuous efforts will secure a future of healthcare services for the people. We take full responsibility for public health and safety, thoroughly understanding all aspects by taking the closest look and the deepest dive into them. We offer a range of systems and services, prioritizing people's right to information and valuing them as health service consumers. We provide a service that allows patients to verify whether the health services they received are covered or not. Furthermore, we make non-reimbursable health service items accessible to patients for their informed and reasonable decisions. We require hospitals to clarify uncovered health services to their patients before consultation. We also allow people to easily access to health-related information on their mobile phone. The Medication History Verification Service stands out as a remarkable public service. Through this service, patients can track the medicines they have taken in real time. It operates by utilizing pharmaceutical information collected during the prescription and dispensing process. Drug Information Provision Service is another public service that enables patients to easily check details like expiration dates and warnings by scanning the barcode with their mobile phones. We also offer a top top-rated hospital finder service, making it easy for people to find the hospitals they most need, right in their neighborhood. We are promoting and extending various services so that everyone can enjoy more prosperous health services. HIRA has always been with the people, even in an unprecedented national crisis like COVID-19. As a lead healthcare institution, HIRA supported the pandemic response at the entire process with state-of-the-art ICT capacities, advanced human resources, and materials. We also have led by example in promoting the best practices of our quarantine policies and healthcare services that played a significant role in response to the pandemic. In particular, we raised the national status and competitiveness by exporting Korea's healthcare system to Bahrain and providing tailored healthcare policy consultation to many countries. There is a reason that we stick to our principle more stubbornly than anyone else, because we know the potential and power behind the commitment and perseverance to uphold the basics. We believe that today's principles become a driving force of tomorrow. With this belief, we're dedicated to shaping an advanced healthcare environment where everyone can enjoy health and happiness. Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. It fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services so that it could contribute to enhancing health and social security for the people. Some people say we are quite stubborn and strict. However, there are solid principles that we must stick to no matter how hard it is. Fairness to save the health and safety of the people. Trust to establish quality healthcare system for everyone. Expertise to accelerate Korea's healthcare system and to take the lead in highly advanced medical environment. And connectivity through consistent cooperation and communication with the people and stakeholders. We will navigate ourselves to the destination we set by the 4 principles, no matter what it is. As we gather years of experiences and know-hows, and as the people and hospitals expect more from us, we naturally push ourselves toward a higher standard. We've never been afraid of taking on challenging risks. Long before the global shift towards digital transformation, we were already harnessing the power of our advanced ICT system to collect healthcare data. This seamlessly interconnected data plays a pivotal role in our daily operations and regenerates new value-added information. This concerted effort contributes significantly to delivering enhanced healthcare services for the benefit of the people. The essence of HIRA is reflected in its commitment to review and assessment. We objectively and fairly evaluate service claims submitted by providers to ensure that they align with our legal criteria and requirements. This ensures that health insurance premiums are maximally utilized for the benefit of the people. Additionally, we assess hospitals to determine if they deliver the most effective medical services from the patient's perspectives. We share these results with the public, contributing to the elevation of healthcare quality. Another responsibility of HIRA involves establishing the benefit criteria covered by the National Health Insurance. We define and monitor the suitability of benefit criteria for both providers and patients by regularly and incrementally updating reimbursable health services. Moreover, we assess whether to list new health products and technologies in the benefit package. This helps ease the financial burden on patients and enhances healthcare accessibility. We enhance the accuracy of claim reviews and quality assessments through Integrated Healthcare Resource Portal. This portal serves as a platform through which hospitals share essential data, including information about human resources, facilities, and equipment. The Drug Utilization Review is a real-time solution that provides doctors and pharmacists with vital drug information during the prescription and dispensing processes to ensure patient safety. This service safeguards the health and safety of individuals by conducting pre-checks on potentially unsafe drugs and ultimately preventing patients from taking such medications. Pharmaceutical Information System plays a pivotal role in patient safety as well. We serve as the command center throughout the entire drug distribution process, spanning from production to supply. This contributes to a transparent and well-managed pharmaceutical distribution system. To predict any possible diseases in the future and revitalize the current medical industry, we are making healthcare big data accessible to academia, medical communities, industries, and the public. As a specialized organization in claim review and quality assessment, we have been actively collaborating with countries around the world in terms of R&D and healthcare projects to create and provide quality healthcare information to the public. We believe that our unwavering and continuous efforts will secure a future of healthcare services for the people. We take full responsibility for public health and safety, thoroughly understanding all aspects by taking the closest look and the deepest dive into them. We offer a range of systems and services, prioritizing people's right to information and valuing them as health service consumers. We provide a service that allows patients to verify whether the health services they received are covered or not. Furthermore, we make non-reimbursable health service items accessible to patients for their informed and reasonable decisions. We require hospitals to clarify uncovered health services to their patients before consultation. We also allow people to easily access to health-related information on their mobile phone. The Medication History Verification Service stands out as a remarkable public service. Through this service, patients can track the medicines they have taken in real time. It operates by utilizing pharmaceutical information collected during the prescription and dispensing process. Drug Information Provision Service is another public service that enables patients to easily check details like expiration dates and warnings by scanning the barcode with their mobile phones. We also offer a top-rated hospital finder service, making it easy for people to find the hospitals they most need, right in their neighborhood. We are promoting and extending various services so that everyone can enjoy more prosperous health services. HIRA has always been with the people, even in an unprecedented national crisis like COVID-19. As a lead healthcare institution, HIRA supported the pandemic response at the entire process with state-of-the-art ICT capacities, advanced human resources and materials. We also have led by example in promoting the best practices of our quarantine policies and healthcare services that played a significant role in response to the pandemic. In particular, we raised the national status and competitiveness by exporting Korea's healthcare system to Bahrain and providing tailored healthcare policy consultation to many countries. There is a reason that we stick to our principle more stubbornly than anyone else, because we know the potential and power behind the commitment and perseverance to uphold the basics. We believe that today's principles become a driving force of tomorrow. With this belief, we're dedicated to shaping an advanced healthcare environment where everyone can enjoy health and happiness. Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. It fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services so that it could contribute to enhancing health and social security for the people. Some people say we are quite stubborn and strict. However, there are solid principles that we must stick to no matter how hard it is. Fairness to save the health and safety of the people. Trust to establish quality healthcare system for everyone. Expertise to accelerate Korea's healthcare system and to take the lead in highly advanced medical environment. And connectivity through consistent cooperation and communication with the people and stakeholders. We will navigate ourselves to the destination we set by the 4 principles, no matter what it is. As we gather years of experiences and know-hows, and as the people and hospitals expect more from us, we naturally push ourselves toward a higher standard. We've never been afraid of taking on challenging risks. Long before the global shift towards digital transformation, we were already harnessing the power of our advanced ICT system to collect healthcare data. This seamlessly interconnected data plays a pivotal role in our daily operations and regenerates new value-added information. This concerted effort contributes significantly to delivering enhanced healthcare services for the benefit of the people. The essence of HIRA is reflected in its commitment to review and assessment. We objectively and fairly evaluate service claims submitted by providers to ensure that they align with our legal criteria and requirements. This ensures that health insurance premiums are maximally utilized for the benefit of the people. Additionally, we assess hospitals to determine if they deliver the most effective medical services from the patient's perspectives. We share these results with the public, contributing to the elevation of healthcare quality. Another responsibility of HIRA involves establishing the benefit criteria covered by the National Health Insurance. We define and monitor the suitability of benefit criteria for both providers and patients by regularly and incrementally updating reimbursable health services. Moreover, we assess whether to list new health products and technologies in the benefit package. This helps ease the financial burden on patients and enhances healthcare accessibility. We enhance the accuracy of claim reviews and quality assessments through Integrated Healthcare Resource Portal. This portal serves as a platform through which hospitals share essential data, including information about human resources, facilities, and equipment. The Drug Utilization Review is a real-time solution that provides doctors and pharmacists with vital drug information during the prescription and dispensing processes to ensure patient safety. This service safeguards the health and safety of individuals by conducting pre-checks on potentially unsafe drugs and ultimately preventing patients from taking such medications. Pharmaceutical Information System plays a pivotal role in patient safety as well. We serve as the command center throughout the entire drug distribution process, spanning from production to supply. This contributes to a transparent and well-managed pharmaceutical distribution system. To predict any possible diseases in the future and revitalize the current medical industry, we are making healthcare big data accessible to academia, medical communities, industries, and the public. As a specialized organization in claim review and quality assessment, we have been actively collaborating with countries around the world in terms of R&D and healthcare projects to create and provide quality healthcare information to the public. We believe that our unwavering and continuous efforts will secure a future of healthcare services for the people. We take full responsibility for public health and safety, thoroughly understanding all aspects by taking the closest look and the deepest dive into them. We offer a range of systems and services, prioritizing people's right to information and valuing them as health service consumers. We provide a service that allows patients to verify whether the health services they received are covered or not. Furthermore, we make non-reimbursable health service items accessible to patients for their informed and reasonable decisions. We require hospitals to clarify uncovered health services to their patients before consultation. We also allow people to easily access to health-related information on their mobile phone. The Medication History Verification Service stands out as a remarkable public service. Through this service, patients can track the medicines they have taken in real time. It operates by utilizing pharmaceutical information collected during the prescription and dispensing process. Drug Information Provision Service is another public service that enables patients to easily check details like expiration dates and warnings by scanning the barcode with their mobile phones. We also offer a top-rated hospital finder service, making it easy for people to find the hospitals they most need, right in their neighborhood. We are promoting and extending various services so that everyone can enjoy more prosperous health services. HIRA has always been with the people, even in an unprecedented national crisis like COVID-19. As a lead healthcare institution, HIRA supported the pandemic response at the entire process with state-of-the-art ICT capacities, advanced human resources, and materials. We also have led by example in promoting the best practices of our quarantine policies and healthcare services that played a significant role in response to the pandemic. In particular, we raised the national status and competitiveness by exporting Korea's healthcare system to Bahrain and providing tailored healthcare policy consultation to many countries. There is a reason that we stick to our principle more stubbornly than anyone else, because we know the potential and power behind the commitment and perseverance to uphold the basics. We believe that today's principles become a driving force of tomorrow. With this belief, we're dedicated to shaping an advanced healthcare environment where everyone can enjoy health and happiness. Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. It fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services so that it could contribute to enhancing health and social security for the people. Some people say we are quite stubborn and strict. However, there are solid principles that we must stick to no matter how hard it is. Fairness to save the health and safety of the people. Trust to establish quality healthcare system for everyone. Expertise to accelerate Korea's healthcare system and to take the lead in highly advanced medical environment. And connectivity through consistent cooperation and communication with the people and stakeholders. We will navigate ourselves to the destination we set by the 4 principles, no matter what it is. As we gather years of experiences and know-hows, and as the people and hospitals expect more from us, we naturally push ourselves toward a higher standard. We've never been afraid of taking on challenging risks. Long before the global shift towards digital transformation, we were already harnessing the power of our advanced ICT system to collect healthcare data. This seamlessly interconnected data plays a pivotal role in our daily operations and regenerates new value-added information. This concerted effort contributes significantly to delivering enhanced healthcare services for the benefit of the people. The essence of HIRA is reflected in its commitment to review and assessment. We objectively and fairly evaluate service claims submitted by providers to ensure that they align with our legal criteria and requirements. This ensures that health insurance premiums are maximally utilized for the benefit of the people. Additionally, we assess hospitals to determine if they deliver the most effective medical services from the patient's perspectives. We share these results with the public, contributing to the elevation of healthcare quality. Another responsibility of HIRA involves establishing the benefit criteria covered by the National Health Insurance. We define and monitor the suitability of benefit criteria for both providers and patients by regularly and incrementally updating reimbursable health services. Moreover, we assess whether to list new health products and technologies in the benefit package. This helps ease the financial burden on patients and enhances healthcare accessibility. We enhance the accuracy of claim reviews and quality assessments through Integrated Healthcare Resource Portal. This portal serves as a platform through which hospitals share essential data, including information about human resources, facilities, and equipment. The Drug Utilization Review is a real-time solution that provides doctors and pharmacists with vital drug information during the prescription and dispensing processes to ensure patient safety. This service safeguards the health and safety of individuals by conducting pre-checks on potentially unsafe drugs and ultimately preventing patients from taking such medications. Pharmaceutical Information System plays a pivotal role in patient safety as well. We serve as the command center throughout the entire drug distribution process, spanning from production to supply. This contributes to a transparent and well-managed pharmaceutical distribution system. To predict any possible diseases in the future and revitalize the current medical industry, we are making healthcare big data accessible to academia, medical communities, industries, and the public. As a specialized organization in claim review and quality assessment, we have been actively collaborating with countries around the world in terms of R&D and healthcare projects to create and provide quality healthcare information to the public. We believe that our unwavering and continuous efforts will secure a future of healthcare services for the people. We take full responsibility for public health and safety, thoroughly understanding all aspects by taking the closest look and the deepest dive into them. We offer a range of systems and services, prioritizing people's right to information and valuing them as health service consumers. We provide a service that allows patients to verify whether the health services they received are covered or not. Furthermore, we make non-reimbursable health service items accessible to patients for their informed and reasonable decisions. We require hospitals to clarify uncovered health services to their patients before consultation. We also allow people to easily access to health-related information on their mobile phone. The Medication History Verification Service stands out as a remarkable public service. Through this service, patients can track the medicines they have taken in real time. It operates by utilizing pharmaceutical information collected during the prescription and dispensing process. Drug Information Provision Service is another public service that enables patients to easily check details like expiration dates and warnings by scanning the barcode with their mobile phones. We also offer a top-rated hospital finder service, making it easy for people to find the hospitals they most need, right in their neighborhood. We are promoting and extending various services so that everyone can enjoy more prosperous health services. HIRA has always been with the people, even in an unprecedented national crisis like COVID-19. As a lead healthcare institution, HIRA supported the pandemic response at the entire process with state-of-the-art ICT capacities, advanced human resources, and materials. We also have led by example in promoting the best practices of our quarantine policies and healthcare services that played a significant role in response to the pandemic. In particular, we raised the national status and competitiveness by exporting Korea's healthcare system to Bahrain and providing tailored healthcare policy consultation to many countries. There is a reason that we stick to our principle more stubbornly than anyone else, because we know the potential and power behind the commitment and perseverance to uphold the basics. We believe that today's principles become a driving force of tomorrow. With this belief, we're dedicated to shaping an advanced healthcare environment where everyone can enjoy health and happiness. Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. it fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services so that it could contribute to enhancing health and social security for the people. Some people say we are quite stubborn and strict. However, there are solid principles that we must stick to, no matter how hard it is. Fairness to save the health and safety of the people. Trust to establish quality healthcare system for everyone. Expertise to accelerate Korea's healthcare system and to take the lead in highly advanced medical environment. And connectivity through consistent cooperation and communication with the people and stakeholders. We will navigate ourselves to the destination we set by the 4 principles, no matter what it is. As we gather years of experiences and know-hows, and as the people and hospitals expect more from us, we naturally push ourselves toward a higher standard. We've never been afraid of taking on challenging risks. Long before the global shift towards digital transformation, we were already harnessing the power of our advanced ICT system to collect healthcare data. This seamlessly interconnected data plays a pivotal role in our daily operations and regenerates new value-added information. This concerted effort contributes significantly to delivering enhanced healthcare services for the benefit of the people. The essence of HIRA is reflected in its commitment to review and assessment. We objectively and fairly evaluate service claims submitted by providers to ensure that they align with our legal criteria and requirements. This ensures that health insurance premiums are maximally utilized for the benefit of the people. Additionally, we assess hospitals to determine if they deliver the most effective medical services from the patient's perspectives. We share these results with the public, contributing to the elevation of healthcare quality. Another responsibility of HIRA involves establishing the benefit criteria covered by the National Health Insurance. We define and monitor the suitability of benefit criteria for both providers and patients by regularly and incrementally updating reimbursable health services. Moreover, we assess whether to list new health products and technologies in the benefit package. This helps ease the financial burden on patients and enhances healthcare accessibility. We enhance the accuracy of claim reviews and quality assessments through Integrated Healthcare Resource Portal. This portal serves as a platform through which hospitals share essential data, including information about human resources, facilities, and equipment. The Drug Utilization Review is a real-time solution that provides doctors and pharmacists with vital drug information during the prescription and dispensing processes to ensure patient safety. This service safeguards the health and safety of individuals by conducting pre-checks on potentially unsafe drugs and ultimately preventing patients from taking such medications. Pharmaceutical Information System plays a pivotal role in patient safety as well. We serve as the command center throughout the entire drug distribution process, spanning from production to supply. This contributes to a transparent and well-managed pharmaceutical distribution system. To predict any possible diseases in the future and revitalize the current medical industry, we are making healthcare big data accessible to academia, medical communities, industries, and the public. As a specialized organization in claim review and quality assessment, we have been actively collaborating with countries around the world in terms of R&D and healthcare projects to create and provide quality healthcare information to the public. We believe that our unwavering and continuous efforts will secure a future of healthcare services for the people. We take full responsibility for public health and safety, thoroughly understanding all aspects by taking the closest look and the deepest dive into them. We offer a range of systems and services, prioritizing people's right to information and valuing them as health service consumers. We provide a service that allows patients to verify whether the health services they received are covered or not. Furthermore, we make non-reimbursable health service items accessible to patients for their informed and reasonable decisions. We require hospitals to clarify uncovered health services to their patients before consultation. We also allow people to easily access to health-related information on their mobile phone. The Medication History Verification Service stands out as a remarkable public service. Through this service, patients can track the medicines they have taken in real time. It operates by utilizing pharmaceutical information collected during the prescription and dispensing process. Drug Information Provision Service is another public service that enables patients to easily check details like expiration dates and warnings by scanning the barcode with their mobile phones. We also offer a top-rated hospital finder service, making it easy for people to find the hospitals they most need, right in their neighborhood. We are promoting and extending various services so that everyone can enjoy more prosperous health services. HIRA has always been with the people, even in an unprecedented national crisis like COVID-19. As a lead healthcare institution, HIRA supported the pandemic response at the entire process with state-of-the-art ICT capacities, advanced human resources, and materials. We also have led by example in promoting the best practices of our quarantine policies and healthcare services that played a significant role in response to the pandemic. In particular, we raised the national status and competitiveness by exporting Korea's healthcare system to Bahrain and providing tailored healthcare policy consultation to many countries. There is a reason that we stick to our principle more stubbornly than anyone else, because we know the potential and power behind the commitment and perseverance to uphold the basics. We believe that today's principles become a driving force of tomorrow. With this belief, we're dedicated to shaping an advanced healthcare environment where everyone can enjoy health and happiness. Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. It fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services so that it could contribute to enhancing health and social security for the people. Some people say we are quite stubborn and strict. However, there are solid principles that we must stick to no matter how hard it is. Fairness to save the health and safety of the people. Trust to establish quality healthcare system for everyone. Expertise to accelerate Korea's healthcare system and to take the lead in highly advanced medical environment. And connectivity through consistent cooperation and communication with the people and stakeholders. We will navigate ourselves to the destination we set by the 4 principles, no matter what it is. As we gather years of experiences and know-hows, and as the people and hospitals expect more from us, we naturally push ourselves toward a higher standard. We've never been afraid of taking on challenging risks. Long before the global shift towards digital transformation, we were already harnessing the power of our advanced ICT system to collect healthcare data. This seamlessly interconnected data plays a pivotal role in our daily operations and regenerates new value-added information. This concerted effort contributes significantly to delivering enhanced healthcare services for the benefit of the people. The essence of HIRA is reflected in its commitment to review and assessment. We objectively and fairly evaluate service claims submitted by providers to ensure that they align with our legal criteria and requirements. This ensures that health insurance premiums are maximally utilized for the benefit of the people. Additionally, we assess hospitals to determine if they deliver the most effective medical services from the patient's perspectives. We share these results with the public, contributing to the elevation of healthcare quality. Another responsibility of HIRA involves establishing the benefit criteria covered by the National Health Insurance. We define and monitor the suitability of benefit criteria for both providers and patients by regularly and incrementally updating reimbursable health services. Moreover, we assess whether to list new health products and technologies in the benefit package. This helps ease the financial burden on patients and enhances healthcare accessibility. We enhance the accuracy of claim reviews and quality assessments through Integrated Healthcare Resource Portal. This portal serves as a platform through which hospitals share essential data, including information about human resources, facilities, and equipment. The Drug Utilization Review is a real-time solution that provides doctors and pharmacists with vital drug information during the prescription and dispensing processes to ensure patient safety. This service safeguards the health and safety of individuals by conducting pre-checks on potentially unsafe drugs and ultimately preventing patients from taking such medications. Pharmaceutical Information System plays a pivotal role in patient safety as well. We serve as the command center throughout the entire drug distribution process, spanning from production to supply. This contributes to a transparent and well-managed pharmaceutical distribution system. To predict any possible diseases in the future and revitalize the current medical industry, we are making healthcare big data accessible to academia, medical communities, industries, and the public. As a specialized organization in claim review and quality assessment, we have been actively collaborating with countries around the world in terms of R&D and healthcare projects to create and provide quality healthcare information to the public. We believe that our unwavering and continuous efforts will secure a future of healthcare services for the people. We take full responsibility for public health and safety, thoroughly understanding all aspects by taking the closest look and the deepest dive into them. We offer a range of systems and services, prioritizing people's right to information and valuing them as health service consumers. we provide a service that allows patients to verify whether the health services they received are covered or not. Furthermore, we make non-reimbursable health service items accessible to patients for their informed and reasonable decisions. We require hospitals to clarify uncovered health services to their patients before consultation. We also allow people to easily access to health-related information on their mobile phone. The Medication History Verification Service stands out as a remarkable public service. Through this service, patients can track the medicines they have taken in real time. It operates by utilizing pharmaceutical information collected during the prescription and dispensing process. Drug Information Provision Service is another public service that enables patients to easily check details like expiration dates and warnings by scanning the barcode with their mobile phones. We also offer a top-rated hospital finder service, making it easy for people to find the hospitals they most need, right in their neighborhood. We are promoting and extending various services so that everyone can enjoy more prosperous health services. HIRA has always been with the people, even in an unprecedented national crisis like COVID-19. As a lead healthcare institution, HIRA supported the pandemic response at the entire process with state-of-the-art ICT capacities, advanced human resources, and materials. We also have led by example in promoting the best practices of our quarantine policies and healthcare services that played a significant role in response to the pandemic. In particular, we raised the national status and competitiveness by exporting Korea's healthcare system to Bahrain and providing tailored healthcare policy consultation to many countries. There is a reason that we stick to our principle more stubbornly than anyone else, because we know the potential and power behind the commitment and perseverance to uphold the basics. We believe that today's principles become a driving force of tomorrow. With this belief, we're dedicated to shaping an advanced healthcare environment where everyone can enjoy health and happiness. Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. It fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services, so that it could contribute to enhancing health and social security for the people. Some people say we are quite stubborn and strict. However, there are solid principles that we must stick to, no matter how hard it is. Fairness to save the health and safety of the people. Trust to establish quality healthcare system for everyone. Expertise to accelerate Korea's healthcare system and to take the lead in highly advanced medical environment. And connectivity through consistent cooperation and communication with the people and stakeholders. We will navigate ourselves to the destination we set by the 4 principles, no matter what it is. As we gather years of experiences and know-hows, and as the people and hospitals expect more from us, we naturally push ourselves toward a higher standard. We've never been afraid of taking on challenging risks. Long before the global shift towards digital transformation, we were already harnessing the power of our advanced ICT system to collect healthcare data. This seamlessly interconnected data plays a pivotal role in our daily operations and regenerates new value-added information. This concerted effort contributes significantly to delivering enhanced healthcare services for the benefit of the people. The essence of HIRA is reflected in its commitment to review and assessment. We objectively and fairly evaluate service claims submitted by providers to ensure that they align with our legal criteria and requirements. This ensures that health insurance premiums are maximally utilized for the benefit of the people. Additionally, we assess hospitals to determine if they deliver the most effective medical services from the patient's perspectives. We share these results with the public, contributing to the elevation of healthcare quality. Another responsibility of HIRA involves establishing the benefit criteria covered by the National Health Insurance. We define and monitor the suitability of benefit criteria for both providers and patients by regularly and incrementally updating reimbursable health services. Moreover, we assess whether to list new health products and technologies in the benefit package. This helps ease the financial burden on patients and enhances healthcare accessibility. We enhance the accuracy of claim reviews and quality assessments through Integrated Healthcare Resource Portal. This portal serves as a platform through which hospitals share essential data, including information about human resources, facilities, and equipment. The Drug Utilization Review is a real-time solution that provides doctors and pharmacists with vital drug information during the prescription and dispensing processes to ensure patient safety. This service safeguards the health and safety of individuals by conducting pre-checks on potentially unsafe drugs and ultimately preventing patients from taking such medications. Pharmaceutical Information System plays a pivotal role in patient safety as well. We serve as the command center throughout the entire drug distribution process, spanning from production to supply. This contributes to a transparent and well-managed pharmaceutical distribution system. To predict any possible diseases in the future and revitalize the current medical industry, we are making healthcare big data accessible to academia, medical communities, industries, and the public. As a specialized organization in claim review and quality assessment, we have been actively collaborating with countries around the world in terms of R&D and healthcare projects to create and provide quality healthcare information to the public. We believe that our unwavering and continuous efforts will secure a future of healthcare services for the people. We take full responsibility for public health and safety, thoroughly understanding all aspects by taking the closest look and the deepest dive into them. We offer a range of systems and services, prioritizing people's right to information and valuing them as health service consumers. We provide a service that allows patients to verify whether the health services they received are covered or not. Furthermore, we make non-reimbursable health service items accessible to patients for their informed and reasonable decisions. We require hospitals to clarify uncovered health services to their patients before consultation. We also allow people to easily access to health-related information on their mobile phone. The Medication History Verification Service stands out as a remarkable public service. Through this service, patients can track the medicines they have taken in real time. It operates by utilizing pharmaceutical information collected during the prescription and dispensing process. Drug Information Provision Service is another public service that enables patients to easily check details like expiration dates and warnings by scanning the barcode with their mobile phones. We also offer a top-rated hospital finder service, making it easy for people to find the hospitals they most need, right in their neighborhood. We are promoting and extending various services so that everyone can enjoy more prosperous health services. HIRA has always been with the people, even in an unprecedented national crisis like COVID-19. As a lead healthcare institution,
네, 여러분.
Ladies and gentlemen, please be seated. Thank you for joining once again. Thank you for staying with us until 3 the afternoon. We'll begin the afternoon session of the 2024 HIRA International Symposium. I hope everyone enjoyed their lunch. Once again, thank you for joining us and please stay with us until the end. We have those joining us online as well in the afternoon, so please stay with us. In sessions 1 and 2, we will explore the evaluation of high-cost drugs based on real-world data through case studies from various countries. Each session will include 2 presentations followed by a panel discussion.
세션 2를 시작할
So now let's get started with session 1. Let me introduce the first speaker. We have Dr. Bor-Sheng, Professor of National Taiwan University Cancer Center. He will be giving us a presentation on utilizing RWD-RWE to reimburse high-cost medicine experiences and challenges in Taiwan. And to introduce our professor, Professor Bor-Sheng is involved in building data banks, integrating big data analytics and machine learning into medical practice at National Taiwan University Cancer Center, and also serves as the co-chair of Expert Advisory Committee of Taiwan, NIA. He is here with us in person, so please welcome him with a big round of applause.
NTUCC. Please welcome him with a big round of applause.
Okay, thank you. And I think in the beginning, I'd like to thank for the HIRA to invite me to this Congress. I think this Congress is very successful in the morning session. And in the next 30 minutes, I think I'd like to briefly introduce how Taiwan health insurance introduce real-world evidence in dealing with treatment in especially in high-cost device and medicines. And this is my presentation slide. The first, I'd like to have a very brief introduction about how the real-world evidence for drug assessment. And then I will go through the Taiwan situation in the past. First, briefly introduce the Taiwan health insurance system, and then give 2 very important examples in the past. And finally, I'd like to go to the evolving strategy for Taiwan insurance about the high-cost medicines. Okay, this slide is very briefly highlighted. In the past, we have different kinds of the data can be used in drug assessment. I think 2 most important types. The first one would be trial. The second type would be real-world evidence. But actually, in the past 10 years, we found that their border become blunt and blunt. And you can see from the slide, from the interventional clinical trial to observational real-world evidence, there are various in middle parts of the experimental design, including pragmatic clinical trial and so on. But today, I will not go through the details because I think most of you will be familiar with this kind of evidence. And also, the real-world data and the real evidence can be applied in different life cycles in the health technology. I think in the beginning, in the very early beginning of the drug or medical device development, clinical trial is very important to get evidence in the controlled environment. But as the approval process becomes faster and faster, less evidence will begin before the drug or the device was approved. So more and more real-world evidence, including various kinds of evidence, including electronic health records, insurance data, survey, biobank, registry, then come into our world and will be very important in the late life cycle of the health technology. And why we should need the real-world evidence in the cost-effectiveness or efficacy analysis, I think there are two most important issues that we may find. The first is that when we got the drug approval, actually we have a fast track, priority track, accelerated track for drug approval. And you can see from the slide that the US FDA approved new drug faster and faster in the past 40 years. Anyway, when they pass the regulatory approval, when they get into the health technology assessment regarding the financial issues, less evidence than we can get from the value for the value assessment. And it is more difficulty, even more in enroll some small scale population. Therefore, confirmatory data cannot be confirmed at the time of the HTA evaluation. And then second issue is clinical trial almost set in a very strict inclusion criteria. Therefore, the population is quite different from the real world setting. So a drug was proven to be effective in the clinical trial, not necessarily in the real world setting, because the general population actually is different from the clinical trial. You can know that the clinical trial has the criteria usually with liver functions, renal function, and so on. And in the real world, we cannot exclude this kind of patient from the use. So we don't know exactly what's the true efficacy after the drug was approved in the market. And therefore, real-world evidence become more and more important. In various countries, I think they have a different kind of use of the real-world evidence. For example, in United States, the most famous example would be the Inflation Reduction Action announced in 2022. Actually, it has a part regarding to reform the healthcare systems, including the Medicare Part D program reform, Medicare Part B cap for inflations. Then especially they introduce a medical price negotiation process. They can choose the drug. The drug can be chosen on the right side, and as you can see, no matter in the small molecular or biosimilar biological medications, actually when they exceed certain amount of expenditure, and when they get into the market to more than several years, for example, in the small molecular, more than 7 years, they can be selected as the negotiating target for the IRA. And then they implement a very complicated structure to trying to determine the so-called maximum fair price (MFP). And the real-world evidence, because all these drugs almost launched in the market for several years, therefore is very important during the negotiation process. And it was suggested there are various real-world evidence methodology in this process. I will not go through the detail because I think the strategy is evolving, and maybe later other speakers can give us more information about this issue. And also in the morning session, we have see that the EMA and the EU net HTA has a collaboration in various ways to use real-world data. And you can find in the EMA EU HTA collaboration plans in 2021, they endorsed the real-world evidence development as a joint project. And since this year, I think the parallel joint scientific consultation, as mentioned in the early morning, become a very important issue. It can reduce the submission time from the drug application to the drug approval and the drug reimbursement in each countries. And most importantly, they can reduce the diverse administrative process and the evidence generation across the Europe in different countries. So I'd like to talk about the Taiwan situation. Of course, in Taiwan, the real-world evidence becomes an important part to evaluation high-cost medications. But I may say that in Taiwan, in the past, we have various real-world data structures in Taiwan. The most famous one would be the NHI research database. It's a claim database. And it can link to different kinds of data sources, as you can see from the slide, including the socioeconomic, the family factors, and also can link to cancer registry. And especially it can be possible to link to the hospital information under certain restriction. But I must say that in the past, when we use the NHI research database, especially in cancer drugs, the efficacy data and the patient-reported outcome actually is lacking. So it will be a problem when we try to implement the real-world data and the real evidence in Taiwan situation, especially for high-cost drug. And I also like to mention some important differences or issues of Taiwan National Health Insurance to the rest part of the world. The first would be the Taiwan implement a very strict global budget system. As you can see from the slide, I just summarized that the process for the global budget system in Taiwan. The first is that the aim for the budget system is try to cap the overall expenditure for the Taiwan National Health Insurance. For every year, we have a committee to set up an annual budget for the next fiscal year, including the medical cost in medical service and also the drug and the medical device. The determination actually is on the national level by the National Developmental Council. And for the next year, when this budget has been set, during this year, actually, we must calculate a so-called point value. It means that the point value is calculated by the overall the global budget amount to the total amount of the medical service, including drugs, medical device, and the pharmaceuticals. However, the pharmaceuticals and the medical device has a fixed value. It means that it has a 1 point for 1 national Taiwan dollars, but the medical service does not. So the third part of this system is that we must calculate the point value for the medical service to fit the final overall expenditure into the overall global budget. And these were very important issues that because the pharmaceuticals and the device has a fixed amount of the cost, but the medical service has a different amount of cost and can be compromised by the medical service and the medical and the pharmaceutical drugs. So in general, I think there will be a problem later when I show you that in the system of the drug pricing, it will happen that different objection will come from the different part of the stakeholder. And then finally, the government will try to ensure that the overall budget will stay in the cap, definitely. And this is for the reference that actually we have a very complicated process on the national level to determine the overall global budget. I won't go to the detail, it is for your reference. And this is for the drug pricing determining the structures in Taiwan. As you can see, the drug application can first pass the expert panel for review assisted by the HTA agency in Taiwan. And then the final determination was conducted by so-called PBI's joint committee. Here is the PBI's stakeholder, including the officers, healthcare, and the employers, and the scholars, and the patient representatives. Anyway, in this process, as you can see from the previous slide regarding the global budget, the system, the healthcare providers actually will usually opposed to high-cost drug because the high-cost drug, once they was reimbursed by the system, it will cause the reduction of the point value in the healthcare system, and therefore reduce and compromise the running of the hospital and the other medical service. So in general, in summary, I summarized the problem to assess high-cost medicine in Taiwan National Health Insurance. The first is that we have inadequate investment. In Taiwan, it is estimated that health expenditure takes only 6.5% of the Taiwan GDP. It's far more than the OECD average. The second, as I mentioned, that the global budget system has a very important compromise effect on the drug reimbursement in Taiwan, because it will compromise the point value in the medical service, and the medical providers frequently oppose the high cost drug reimbursement in PBI's joint meeting. The third, of course, comes from the science. Currently, in the high-cost medications, we usually have inadequate evidence. First is that most trial is conducted in the Western country, and we lack the racial and the geographic difference description in review. And also, difference in trial and real-world population will also encounter problems in Taiwan. So in the past 10 years in Taiwan, we faced this situation for several times, and I'd like to pose two of the most important to use the real-world evidence to solve this problem. The first would be that to use direct acting antiviral agent for hepatitis C. This slide highlights the background information for you. The DAA for hepatitis C actually is an important issue in Taiwan because Taiwan is the HCV endemic area. As you can see from the right upper part of the slide, the incidence was as high as 5% for the general population. And it is estimated the case will be 270,000 in Taiwan every year. And as you know, HCV usually evolving into liver cirrhosis and hepatocellular carcinoma, which requires more expensive medical care and drugs. And the treatment can definitely improve the survival. In the past, old generation drugs, the sustained viral response, SVR, plays an important role as a surrogate indicator for the treatment. But since 2015, actually we have a new generation drug called the DAA. DAA is a novel treatment for hepatitis C, and the response rate can be elevated from in the old generation as low as 30% to 85 to 100% for the DAA. Anyway, I think the DAA, you don't need to do a pharmacoeconomic study. You can directly conclude that it is definitely cost-effective because it reduces so many costs for patients in liver cirrhosis and hepatocellular carcinoma. Actually, this issue in Taiwan will be a problem because they will have a very huge, I call it immediately budget impact. It is estimated for the listing price about $33,000 for treat one patient will finally cost almost $9 billion in Taiwan health insurance. This is intolerable for the health insurance in Taiwan. Anyway, the Taiwan government came into this problem, so they finally still decide to listing DAA, but with the following model. The first is that actually we will not eliminate the HCV in 1 year, but in 10 years. So the budget can be divided into 10 years. And we set an annual budget, as you can see from the slide, the annual budget will be $100 million for 1 year, for less than for 10 years. And therefore, we need to treat this kind of patient in 10 years. And therefore, the government collaborate with the academic society to set up reimbursement criteria to ensure that the cost can be evenly distributed in the 10 years. And then the government go back to negotiate with the pharmaceuticals. When they negotiate with the pharmaceuticals, the performance-based MEA was suggested. So the SVR at the 12th weeks will be the outcome target as a surrogate endpoint. And at that time, there is 3 kinds of medication, so the government has a negotiation power with a single payer system. And to ensure the response, the government funded a project with a registration system run by the academic society. The society called the TASW, I will see in the later slide. So this is the whole pictures for the model of listing DAS in Taiwan. And this is the setup, the timeline for the DAA run by the society. And the society planned the three stages of the elimination plans in here. I will not go to the detail because it is regarding to the specialist medicines. I will not familiar with that also, okay. And also the government funded the registration on actually run by the TASL, a liver study society in Taiwan. And it was linked to the reimbursement by the criteria. The first is that those who fail to report the data in the hospital will not be reimbursed by the system. The second is that for the manufacturers, those who fail the milestones, it means that SVR 12 will be the cost will be refunded from the pharmaceuticals. And this is a very simple registration system. You just need to enter this kind of information, and then you can gather the reimbursement. And finally, the government set up a transparency reporting system for the outcome of the registration. This is also run and available in the internet website on the following. You can show that till the last month, actually the government estimates to screen about 60% of the HCV patients and treat about 80% of the HCV patients, and the treatment success rate is very high as 95%. And the right side is the publication from the society, indicate a very high SVR20 and even in the different genome type. So this is the successful role for government to introduce real-world evidence and the negotiation power to conquer major healthcare system problem. And the next will be even more important. It's called the immune checkpoint inhibitor for cancers. And again, I give you some background information. Immune checkpoint inhibitor, example PD-1 or PD-L1 inhibitors actually is important in cancer treatment in the past 10 years. Actually, we found that the indication rapidly expanding to different kinds of cancer. This is only listed the indication till the end of the 2022 in April. You can see that almost the cancers across the body can be treated with immune checkpoint inhibitor. And the data is even better when they combine with chemotherapy or other small molecular target therapy. Anyway, you can see from the right side is a representative study for the immune checkpoint inhibitor called the Keynote 407. It is used in the non-small cell lung cancer. And from this slide, you can see that when you compare with the blue line, the treatment arm, and the red line control arm, actually the difference is not usually large. But at the end of 5 years, you can see that almost 20% to 30% of the patient can be sustained to, cured by this kind of the medication. So it causes a problem. In almost 80% of the cases, the drug effect is little, but in the 20% to 30% of the patient, the drug effect is very large. And also, in some patients may have a very disastrous side effect called hyperprogression. It means that the tumor progression faster than the control arm. So it will be a problem for the government to try to think about the reimbursement such kind of the medicine. And still finally, in the end of the 2018, actually the government finally decided to reimburse the immune checkpoint inhibitor. But it is a deep problem how to reimburse that. Finally, we set up the strategy that we reimbursed all the 11 indication for the 3 immune checkpoint inhibitor at the same time. But we set up an annual budget as 800 million new Taiwan dollars. And it was calculated that we can treat about 800 patients per year. So we set up a registration system and try to use the registration system the first to register the outcome. The second is that to control the number of the patients who get into the treatment program reimbursed by National Health Insurance reimbursement. And the registration system actually is run by the government. The indication item was listed as the slide. Actually, quite a lot of registration items. The item actually was designed differently with per indication, but we refer the pivotal trial, the epidemiology data to design this registration system. And the registration system report actually is compulsory for each one for initial characters, and you need to reply the response every 3 months. And also the government requests the Ayyar report. I presented the first year outcome who ended in the 2020 March. You can see that in the reporting, there's about 1,100 cases can be analyzed by this outcome data. And the indication, different indication, you can see that the response rate is different. And overall, there's only about 30 to 40 cases actually has a stable disease or complete remission or partial remission. And about 13% of the patients experience a hyperprogression, and therefore it is a negative factor for evaluation the efficacy for the immune checkpoint inhibitor. And also, when we compare with the clinical trial data here, you can see from the left side, we compare the clinical trial data and the real-world data at the slide. And also in the right side, we have the report for the adverse event. From this data, we found that the gastric cancer and the hepatocellular carcinoma, when used singly, actually is the most ineffective treatment indications. So in 2020, in the July, actually we delisting the indication for the gastric cancer and the hepatocellular carcinoma from the reimbursement for the immune checkpoint inhibitor in Taiwan. And interestingly, we found that later, maybe 3 to 6 months later, the US FDA also removed the indication for the gastric cancer and the hepatocellular carcinoma for this kind of immune checkpoint inhibitor in their drug list. So actually, it represented a successful example that the real-world data can really have impact on the reimbursement. And this is the latest data to 2024 March. We updated the overall outcome, and you can see that for this kind of cancer, except for the most impressive one, the classical Hodgkin lymphoma, almost all kinds of the cancer, after follow-up 4 years, we can see that the overall survival will reach about 20 to 30% at the end of the 4th year. It was quite comparable with the clinical trial. So since the 2024 July, actually the reimbursement system trying to simplify the registration system. We do not restrict the case to use the immune checkpoint inhibitor anymore. Just want to report the indication, report the user situation for the indication. And this is for the indication-based MEA. And we can still follow up the overall survival by the routine AHI research database. Therefore, the registration system, I think, will be simplified, and maybe removed in some day in the future. So finally, I'd like to go to what we think about how to renovate the national health insurance in Taiwan. Actually, since this year, the Taiwan government, including the MOHW and the NHI, raised the new concept to reform the overall reimbursement system, summarized as this slide. The first is that we are going to have a new HTA infrastructure called the Chapter, Center of Health Policy and Technology Assessment, directly maybe under the exclusive yuan in Taiwan, maybe since the last year or maybe in the next year. And it will be have an independent budget and the personnel and a more strong power to conduct HTA related the studies and the policy situation. And it will have a formal legal structure under the law. The second is that we were trying to reinforce the evidence-based decision-making system. And the first is we will use a so-called conditional listing structure as defined by the slide. The first is that it will use to dealing with the uncertainty for the effectiveness of a budget for new device or medications. And it will allow the government to, or manufacturers to collect evidence in 2 or 5 years and let the new evidence come back to the reimbursement system to have a new price. And an important one is that let's set up an independent budget. As we can see from the previous slide, the global budget system actually has a major impact on the reimbursement in Taiwan. So an independent budget would be very attractive in this way. And in the next 3 to 4 years, actually, the government is planning to establish a cancer drug fund similar to the IMF and the cancer drug fund in UK, trying to reimburse the cancer drug fund and the other innovative medicines. And in Taiwan also, we introduced the HT reassessment, trying to judge the existing drugs and the medical devices price maybe 5 to 10 years after its marketing. And then finally, because Taiwan has a global budget system, it is very important to estimate the potential budget. So not like in other countries to use the way to use a horizon scanning, the Taiwan government introduced a horizon scanning to estimate the budget in the next year and in the next year, trying to make the overall investment for the healthcare system would be more reasonable. And also some administrative effort has been improved in Taiwan. The first I'd like to pose is the rare disease. In Taiwan, actually, rare disease, from the rare disease design to the rare disease drug approval and the reimbursement belong to the different department of the government, including the National Health Insurance System, Food and Drug Administration System, and also the Health Promotion Administration System. It's very complicated. Anyway, in Taiwan, we have several important innovations. The first is that before 1995, we have no such a fast-track pathway. But since 1995, we have a drug recognized as an orphan drug and approval with special import without license is possible. And since 2014, we have a so-called Rare Disease Drug Act. So we have the more integrated administrative system listed as the slide, from the rare disease to rare disease drug and to the overall review process and trying to improve and accelerated the access of the drug for the rare disease. And also the second effort run by the government is that we now, in this year, we start a so-called parallel review pathway. I think the pathway is very similar to the EU net HTA process. You can submit the dossier to the Taiwan FDA and the Taiwan NHI simultaneously. And with the collaboration between these two departments, we can accelerate the process. It was estimated at least about 6 months reduction for the overall process from the drug application to the final reimbursement approval. Anyway, in Taiwan, we now have a free for the submission now, but in the future maybe we'll like the US FDA and the EU HTA will have some cost for the review process. And also I'd like to introduce the so-called conditional listing process in Taiwan. As you know from the previous slide, the drug is used, the situation is used for the drug with a high unmet medical need, but in uncertainty on cost effectiveness or budget impact. A key issue is in the conditional listing is that they need to collect the real-world data to generate real evidence within 2 to 5 years. And this table lists the conditional listed drug since till the end of the last month. And I'd like to post the T-cell cell, the CAR-T, as an example to illustrate how government trying to hard to make a collection of the real-world data. Actually, this is an example for the academic NHI and also the hospitals' collaboration to collect this kind of data. Actually, it's established on the foundation of the Taiwan registry. In the past, Taiwan has a strong transplantation registry system. We established in the 2013 as my presidency in the Taiwan Bone Marrow Transplantation Society. And we hired the data manager and trained by the host society and sent to the center trying to record the data. Therefore, the data quality is quite acceptable and with very high coverage rate, more than 95% of the transplantation case in Taiwan. In 2022, actually we evolved into academic CAR-T registry because at that time self-paid CAR-T has been approved in Taiwan. And it was co-hosted by the Hematology Society and also the Transplantation Society. And we combined the EBNT, ASTCT, it is the International Transplantation Society, as a golden standard for CAR-T registry with more than 200 items in the registration system. And in the last year, actually, Novartis T-cell cell has been approved, and the 7th center was approved to use this kind of medicine. So the first is that we construct IRB data collection and regulation and analysis under the regulation of the institutional IRB for those with the positive, for those can be eligible for CAR-T usage in Taiwan. And since 2023 November, the government reimbursed the T-cell cell in Taiwan, and they request a conditional listing and require the real-world data collection. And also, the government requests the price negotiation every 2 years according to the performance of the T-cell cell. Therefore, the government has a link with the institute. But at that time, the government trying to reach the society about can the government use the registration system run by the society? Initially, I think it's okay for both of us, but when regarding the regulating issue, we found some difficulties. The first is that actually the Institute IRB did not allow to pass individual level data from the society to the NHIA. The second is that the registration power cannot be granted from the NHIA to ask every patient in the institute in the CAR-T to submit the data to the society. So finally, we conduct a different way to collect the data. The first is that the government synchronized with the society about the data format, and that means that what the government want, what the items government want, actually the society would collect. But the society did not submit the data directly to the NHIA. We submitted the data back to the institute because every institute principal investigator has the power to know the data. And the institute, the principal investigator is responsible to report the data from the institute. Therefore, bypass all the legal system problems, but the NHIA can access the individual data as much as possible with the data complementarity as in the society. And then that is the data collection system we run in Taiwan for Kymriah. And the next part will be regarding the data digital transformation and the data integration. In the NHIA, actually they launched some system now trying to use the FHIR system to encode the data across the all treatment journey for the patient using small molecular drugs. And the data format was used so-called the M-code system. This system is going to be launched in the end of this year, and I think in the next 2 or 3 years, the data integration in Taiwan will be more completed, especially for oncology patients. And finally is for the guidance for the real-world generation. In the past, the Taiwan CDE has launched the real-world real-world evidence generation from the real-world data guidance. And in the past year, actually, with the collaboration with the ISPO Taiwan chapter and the NICE, we collaborated to develop a real-world evidence framework that can be followed by the manufacturers and probably will be important guidance for the governments when they're trying to review such kind of the data. So finally, I'd like to summarize my talk. The first is that how to assess high-cost medication actually is a global issue. You can see that the US FDA considers real-world evidence as a price negotiation determinant. And also a similar consideration will be happening in Taiwan. And in Taiwan, in the past, we have several successful examples existed for reimbursement and using the real-world data. Anyway, I think the example actually is case by case in nature because each case is quite complicated in financial issues and also in the data acquiring issues. And in the future, the Taiwan NHI is trying to establish a more systematic approach to use real-world data and the real-world evidence, including renovation of the infrastructure, including new institute, new data collection process. And also we have new pathways in the administration, including parallel review, horizon scanning, conditional approval, and the HTR process. And collaboration with academic society and the manufacturing will be definitely an important direction in the future for Taiwan government to use this kind of data. Thank you very much.
Thank you, Professor. Now please return to your seat, and we'll be having you back to the stage after one more presentation. 고맙습니다. 저희는 잠시 후 한 개의 발표를 더 만나보신 이후에
Okay, so after one more presentation, we will have the panel discussion.
원장님께서
Next, we have a presentation by Dr. Nicole Mittman, Vice President of Canada's Drug Agency. She will be speaking on the topic of real-world evidence for decision-making about high-cost drugs. Dr. Mittman, although she's not here in person, but she's joining us online today. Dr. Mittman is the Chief Scientist overseeing evidence, methodology, and resources at Canada's Drug Agency, where she leads various teams, including those focused on health economics and real-world evidence. Please join me in welcoming Dr. Mittman.
PA is joining us online in real time, and we'd like to welcome her. 여러분 큰 박수로 환영해 주시죠.
A big round of applause, please.
Thank you, Dr. Mittman.
Thank you. Can you hear me?
Yes, we can hear you, and now you may have the floor.
Thank you very much, and good morning, good afternoon, and good night. Thank you very much for the invitation to present at this conference, and apologies for not being there in person. My name is Nicole Mittman. I am the Chief Scientist and Vice President of Scientific Evidence, Methodologies, and Resources at Canada's Drug Agency. You may have heard of us when we were the Canadian Agency for Drugs and Technologies in Health, or CADTH, but we have recently moved into a new organizational name as well. And thank you very much for letting me follow Dr. Ko. Very interesting presentation from Taiwan and the examples. I'm going to take a little bit of a different approach to the presentation and talk about the methodologies, or how we're trying to live the health technology assessment principles of transparency, impartiality, inclusivity, and consistency. But I think I appreciate the phrase, it's very complicated. And we will talk a little bit about that as well. So let me move on and see if I can advance my slides. That's always the challenging part. There we go. So maybe what I'd like to start with is Canada's Drug Agency recognizes the traditional territories and rights and diversity of all First Nations, Inuit and Métis communities across Canada, and our Indigenous peoples have been and continue to be excluded and harmed from Canada's healthcare system. And in the spirit of reconciliation, we are committed to addressing these inequities alongside with the Indigenous communities. So perhaps I'll give you a little bit of an overview, really give you a sense of what we do, who we are, think about how that leverages our strategic plan, and then talk about decision making from a real-world evidence perspective. The crowd is very knowledgeable about real-world evidence. I won't talk too much about budgets, but I will talk about some of the foundational pieces that we're putting together so that we can address the real-world evidence perspective. So if we think about our organization, we're responsible for better coordination, alignment, and public value within Canada's health and technology landscape. We are the second largest landmass country, but we have 14 different payers, and payers from the federal perspective, the provincial perspective, and the territorial perspectives. And our organization sits between the regulator and the payer, and there's also a negotiator that comes through. So this is one of the, and when we say this complicated, it's complicated. I just thought what we'd like to talk about is what we do, and then how does real-world evidence fit into this. We conduct health technology assessments and allows that decision makers to make the best decisions in terms of funding. That allows us, and those kinds of questions allow us to look at how effective is a new drug compared to other drugs. And for this community of audience, we know about the purpose of health technology assessment is really about what is the value of a new technology compared to another technology that may or may not already be into the system. And then how do we actually ensure that we're getting the best value? And we may not have all the right kind of evidence at the beginning. And so we saw earlier in Dr. Koh's presentation, about the clinical trial, and there are other kinds of data sets. So I'll talk a little bit about that. We have recently, as mentioned, become Canada's drug agency. And actually we have our annual symposium, which starts on Tuesday of next week, where we will actually launch the Canada's drug agency. But as part of this, we have our core functions of health technology assessment for drugs and devices and clinical interventions, but we have also then acquired new kinds of areas, for example, appropriate use, data and analytics, and that will become really important for talking about real-world evidence, and then also to improve system coordination. This is some of our new work that we'll be focusing on. Here, just a snapshot of Canada's current healthcare environment. We don't have enough beds, we don't have enough emergency rooms, people are waiting, and then the financial burden of new technologies and the costs of those technologies all comes into play to put a perfect storm into this very complicated system. So I think one of the things is that we just really wanted to understand what is the value of real-world evidence and how can it contribute to help us understand what is the scope or the efficacy or effectiveness and safety of new technologies. So we know real-world evidence is a very hot topic. It was the #1 topic. I think it's now 2 or 3 years in a row at the International Society for Pharmacoeconomics and Outcomes Research, and really just trying to harness the benefit of more data. Because as we've heard earlier, these accelerated platforms from the regulator mean that we're getting more and more immature data, or certainly not as robust data. And that is data that's different than we're used to at a health technology assessment. So how do we manage that? We need to think about other ways of using data to help inform decision making. I don't think I need to tell this audience about what are the definitions of real-world data and real-world evidence, but really as we think about what are how can we look at the effectiveness and the safety and the cost of those particular technologies using data as well. We're all familiar with the evidence pyramid at the end, and thinking about the best kind of evidence is obviously either a systematic review of clinical trials or clinical trials themselves. And then there are other kinds of evidence that can include many types of observational studies, including administrative databases, registries, and then depending on how rare the disease is, it may actually be case series or case studies. And then there are the lowest part of the evidence is really the anecdotal kind of responses to outcomes as well. But this is how we sort of think about it. And in terms of here's a clinical trial, they're often very consistent. That's the grouping of circles on the right-hand side. Individuals who are enrolled in a clinical trial are often only have the disease of interest. They may not have comorbidities, they may not have polypharmacy, they may be good responders, they may be naive responders, and they may be of certain age bands or certain genders or sexes as well. So as we think about what happens in the real world, we're actually not approaching or understanding what's happening in individuals who probably will receive the drugs in actual clinical practice. So how do we then take the clinical trial knowledge and then move that into a space to make it appropriate for somebody's grandmother who might be on 2 or 3 medications or more, and may have more than one disease to consider. And so this is an opportunity to think a little bit around expanding the types of data to help inform the work that we do. So there are things that real-world evidence can do, and there are things that real-world evidence can't do. Often we hear from our industry colleagues that they would like to submit real-world evidence to our organization and to others, and then thinking about getting access. Now, it doesn't actually mean automatic access if you have real-world evidence, but it can fill the gaps and uncertainty. No clinical trial is long enough. No clinical trial is big enough. No clinical trial has always the right population that you're actually seeing in actual clinical practice. So is there an opportunity to look at that data that comes from actual clinical practice? Moreover, more and more clinical trials, as they move through that accelerated pathway, have or use surrogate outcomes or intermediate outcomes that may not be the final outcome of interest to a payer. And so how do we then validate if we're achieving an outcome of interest, and is this an opportunity for real-world evidence? We're all facing this issue, as by having this conference here today means that there are a number of individuals and organizations who are also facing this particular issue. But really the intent is for real-world evidence not to replace a clinical trial. We are not going to turn that evidence pyramid on it upside down. But there will be opportunities to think about fit for purpose work that can be done with real-world evidence. And it should not and does not need to be conducted for everything. We have robust clinical trial programs for very common diseases. There really isn't a need to fill an uncertainty gap. But perhaps for personalized medicine, for rare diseases, where we don't have that robust data and mature data, we need to think about using it in that space. So the way we're thinking about it is it's a complementary, or that we're trying to address gaps that are in part of the clinical trial program. And so thinking about how do we build an infrastructure, or what kind of work do we do to ensure that we have high quality real world evidence that is also included. Or we can talk about real world evidence in the space of what is good about the study, what is bad about the study, and what is ugly about the study. And there's a famous Clint Eastwood movie, The Good, the Bad, and the Ugly. And we often talk about what is the kind of quality of these particular study designs and how do we measure that. And then the integration and the complementary nature will actually help with decision making. So there are gaps. It can certainly address the uncertainties in clinical trials and comparative effectiveness and harms. Many countries have safety programs that use registries or use spontaneous reporting systems where there are measures of harm within the system, and they allow us to look at that. Really, the final frontier of real-world evidence is effectiveness. We use real-world evidence for utilization studies. We use real-world evidence for post-market evaluations. We use real-world evidence for utility or health preference values. We also use real-world evidence for patient-reported outcome measures and/or quality of life. I think what we're really talking about is how do we use or leverage real-world evidence to help us understand effectiveness. So whether the drug actually works in the system. It can provide us with long-term effectiveness and safety information, durability of the treatments. As mentioned, clinical trials actually are limited by the type or the time horizon of the clinical trial, and we don't know once the trial stops what happens to those patients afterwards. So it allows us to think about the patient in the longitudinal way, and also can provide, as already said, contextual information around utilization or quality of life, and support around the implementation, or what are the kinds of resources that are required for implementation. Especially with some of these complex drugs that are coming, they often require either different specialties different diagnostics, different health and human resources. So how do we understand that system? And some of that work can be done with real world data and real world evidence, and really looking at providing inputs for economic models. So how do we understand the disease itself, the trajectory, the epidemiology, and then the healthcare resource utilization? Who goes down what pathway for surgery or radiation or regular oncology treatment, for example? It gives us a sense of how individuals are navigating through the system. But really the final frontier, and where all health technology assessment organizations are struggling, is how we manage effectiveness using real world evidence. So we have the FDA has recently come out with some new uses of real world evidence. There's lots of guidance out there, really just how are they using it for approvals in the regulatory space, and what should submissions include. And really this gives us a little bit of a taste of what information is required in order to have submissions. And really it talks about the type of the study designs. It talks about what are the kinds of contributions where real world evidence and real world data can provide more information. And it really does provide us with some guidance there. But there are other things that we need to think about, especially in the space of high cost drugs. There are often, as mentioned already, immature data. So how do we make this data more robust? How do we decrease that uncertainty or increase the certainty for the health technology assessment agency, and then also for the payers along the way? So if we think about, we've heard a little bit about some of the technologies that were considered in the Taiwan perspective, but all these drugs that are perhaps first in class might not have robust data. Radiopharmaceuticals, personalized medicine, drugs where the place in therapy is unclear, perhaps at the end of the line or first line, drugs that pose new challenges for medical imaging or other diagnostics along the way, and really drugs where there are rare conditions and where the condition is really an opportunity where we don't know that you can get robust evidence, and even enrolling patients with a rare disease into a trial becomes problematic and perhaps even ethically challenging. So what I wanted to say, so in our jurisdiction, in our country, we have just recently put together a national strategy for high-cost drugs for rare diseases. This really was an opportunity to think about treatments that are for rare diseases that are very expensive, and how do we manage those? Because there are these methodological challenges, and we need to think about different ways of approaching the evidence, and then continue perhaps monitoring it, and then thinking about how do we look at accelerated approval. So we worked very closely with our regulator and Health Canada themselves, and they've put a fair bit of funding behind this work in terms of the national strategy, and we'll talk a little bit about that coming up. So as we think about it at our organization, I said I'm taking more of a methodological approach to this discussion, and how do we look at it? And I think there are about 4 different ways that we're looking at real world evidence and thinking about it from how can we understand the quality of the data, what are our data needs, and what do we actually need to have to ensure that we have certainty for the decision maker. And really, at the end of the day, the job of the health technology assessment or agency or organization is to ensure that we have confidence in the data, and to talk about that confidence, and to ensure that the decision makers understand how we've done our work along the way. So we have, as mentioned, a number of different programs. We have an early scientific advice program, and the early scientific advice program sits at often, we have had this program and we often collaborate with NICE, but talking about building clinical trials or building programs, we found that there's more need around, once clinical trial programs are being built, and often globally, that the real questions are around how do we actually think about the creation of real world evidence? How do we put that together? Who needs to be involved? What kind of outcomes? And so we've recently launched, and you'll see in the upcoming slide, an opportunity to provide evidence or advice around what data is acceptable and what data would be useful for decision making. We look at reimbursement reviews for our drugs, for example. What evidence can we use to actually support a reimbursement decision? This becomes an input as health technology assessment is an input, a throughput, and an output. The input is this another type of evidence that we can bring to the deliberation committee that actually looks at the different types of evidence along the way. We have conducted a number of real-world evidence learning projects where we found that we are actually data rich but knowledge poor, and we actually think about how where are the different data sets. We saw nicely on the previous slide deck from the previous speaker about different kinds of databases that are available. We have lots of pockets of data. Each province and territory has their own database around utilization because our healthcare is not a national healthcare system. It is a regional healthcare system. So data sits there across each of the provinces and territories. We also have some federal systems, and so data sits there. And so, but there isn't an opportunity to follow one patient forward in time from birth to death. In fact, they go in and out of different data sets. And one of the things that we learned through our own encounters with the system and our learning period was what are the kinds of databases out there? How accessible are they? And what are the data elements in them? So you might have a data set that actually has demographic information, which may not be linked to a data set that has information on utilization or drug use or device use, which may or may not be linked to an outcome. And so if you wanted to follow and identify an individual forward in time, we're trying to create systems. One of the hot slides I highlighted early on is as we become Canada's drug agency, there was a focus on data and analytics and creating a more robust system that will let us link information appropriately. And our the last thing I wanted to highlight was our post-market drug evaluation program. And this is actually now questions about the effectiveness and the safety using data sets from those different kinds of provinces and territories to answer questions that are important for our regulator, especially if we have our accelerated approval where there sometimes are conditions associated with the regulatory approval itself, and how do we measure those conditions and how do we validate them and move them forward. So this is the scientific advice program. This really helps us understand what are the key gaps in the clinical trial program. Are they using the right kind of outcomes? Are decision makers thinking about different outcomes? Do health technology assessments look at different outcomes as well? So is there an opportunity to either add that into a clinical trial program and or think about putting it into a real world evidence study that might be in a different kind of data set or registry? It helps to identify relevant data sources, and so that the opportunity for the industry and for the sponsor is to put their best foot forward, not only with their clinical trial package, but to think already in advance about what kind of data could be used when we're doing our deliberations, when the decision makers want to actually understand how to continue to measure it as well. And then as we think about that real scientific advice, there's an opportunity to say, well, how will we appraise the real world evidence? And I'll come to that in an upcoming slide. This is sort of our reimbursement review. We've been working on not only accepting what sponsors submit to us in terms of clinical trial programs and to support the evidence for the particular technology, but we also have real world evidence that can be submitted along with the original submission. So not just a resubmission, for example, but with the original or the initial submission, as long as it answers a question or that is actually a gap, right? And I think that those are the kinds of things that we're just trying to actually be consistent and be transparent about. We have received many kinds of real world evidence studies through our pharmaceutical reviews, and they have consisted of everything from a 200-page case report to a peer-reviewed publication and everything in between. And I think this is why the comment you saw earlier, we don't need to do it for everything, but we need to understand when it's useful. And I think that's something that we as a health technology assessment agency and organization can do by providing that kind of guidance. When do we need more evidence? When is it appropriate? And how will we actually assess it along the way? I think this is sort of the post-market drug evaluation space where we have a co-lab group, and this is a program that actually exists at our organization where we work together with academics, we work with various government agencies, we work with decision makers, and they all come together to help answer a question that is important for either from an effectiveness point of view and for a safety point of view. And this is a network across the country that allows us to answer these questions in a very timely manner, because that's really important as well. Sometimes if you think about an academic lens, often these observational studies could take years to complete, and yet we've funded it or we are thinking about funding it, and we really need answers in a more timely way. And there's an actual divide between what's an academic perspective and what is something that a decision maker wants to have. And we have, even from our privacy and ethics work that we have worked on in our organization, there are sort of two streams. One is a research stream and one is a quality improvement stream. And so as we start to move and look at data in a different way, we use research principles or research methodologies, but is the end goal a publication, or is the end goal to inform a decision maker? So just highlight a number of initiatives that we're moving forward with, and I indicated we're looking at a methodological approach. We have encountered challenges, right, with respect to methods, and studies may not be complete and may not be the right kind of study to involve. And so as we're looking at the kinds of data that we receive, we need to understand how we can appraise that real world evidence and what kind of what was the quality of that particular evidence. And as mentioned, we have a range of things that are kinds of studies that are reported to us. Each one requires a case-by-case analysis. Each one requires at least a metric that is common between them to indicate about the quality. And so in the clinical trial space, we use the GRADE tool to help us understand, the quality of the trial. And we are looking to evolve into, can we provide similar kinds of metrics for observational studies? And often when we look at that evidence pyramid, it really is around clinical effectiveness or efficacy and safety. It might actually be a different shape or a different order if you're looking at what drug utilization is, or if you're looking at patient-reported outcomes. So we're looking at different ways and what kind of data would support it. And really the submissions that we have received don't automatically identify the gaps. And so this is an opportunity where does real world evidence actually support in a complementary way the robust clinic or the clinical trial program, which may not be as robust. And there's certainly a lack of standardizing reporting and real world evidence. And that is something that we've learned internationally working with our colleagues at NICE or in the US at Ayyar, that a number of the submissions actually are submitted without any clear protocol. And if we think about the way that clinical trials, we take for granted that a clinical trial has a protocol. We take for granted that it has a consent form. We take for granted that it is registered on clinicaltrials.gov, that there's a data safety monitoring board, that we have all of these checks and balances into a study design. We don't have those assurances in any sort of real world evidence study, whether that is an observational study with an administrative database, whether that's electronic health records, whether that is a registry that is collected for a disease and or a technology. And moreover, as we start to move into the AI space where you're creating synthetic cohorts, we don't know how it was created. And so part of the work that we're trying to do is ensure that we actually understand the types of studies that we're getting and ask questions about those study designs so that we can appraise. So we really can't appraise what we don't know. And we often say that to our submitters and our manufacturers. So what are we missing and when should we appraise? Does the RWE study address the uncertainty? So we have to be very clear about what that uncertainty is. And I think over time, we're getting much more transparent with how we're expecting to see the data and reporting on the data. Remember, I used the input, the throughput, and the output. The output really has to be clear about what that uncertainty is, and then how do we address it? And then what tools do we use? And there are multiple different tools depending on the study design. I'll talk about those later. And then how do we report it? Again, this is the output piece. What are we asking? Are we giving evidence a score? Are we actually creating different algorithms to talk about the quality of the evidence in a very transparent way? And I think as we talk about the tools themselves, we're often interested in, what is the study design? What is the quality of the data? Who did the analysis? Was there any bias associated with? And then looking at different kinds of tools that can actually help us do that work. And one can only think back to COVID when there were two studies, one published in JAMA and the other one published in New England Journal, and it was on hydroxychloroquine, and it was a large database study looking at outcomes, and they both were retracted because they couldn't verify the source of the data. So I think that those are things that really we struggle with when we see data coming to us. It doesn't mean we can't appraise it, but we still need to understand what's part of the studies. And so part of this is we're trying to be as transparent as possible. We're in the midst of putting together a methods manual where we can very transparently and clearly state how we appraise these kinds of study designs and tools. And then the rationale for using a certain tool over another, for example. And this helps then, the more transparent we are, that allows the sponsor or the manufacturer or the industry to put their best foot forward by knowing what we're looking at and knowing what we're looking for. And it certainly, in this methods manual, which will be released in the fall of 2024, really has a section on the appraisal of real world evidence. Again, how do we do our work? It's not enough about just what we use and how we use it, but how do we actually do the appraisal work and with what tools? And then one of the things we did and we launched in 2023 was actually the guidance for reporting real world evidence. And we heard about that from the Taiwanese example, creating some guidance. And really this is an opportunity to say, these are the kinds of elements we're looking for. It isn't a checklist per se, but it allows the individuals or the organizations submitting to us to go through this list to understand what we're expecting to see along the way and how to describe those various kinds of study designs, because you could have a comparative cohort, you could have a case series, you could have a case control study. And so how do we understand what the kinds of studies are? We did this work together with our regulator, Health Canada, and also our sister health technology assessment organization, INES, out of Quebec, because we're a pan-Canadian organization and Quebec has their own, our province of Quebec has their own health technology assessment, but we provided and updated this kind of guidance document for what are the kinds of things real-world evidence studies need to consider and how do we report them. And we leveraged our international work and really tried to put the foundation of the work together and make sure that we were in line and in step with groups like the FDA, groups like NICE as well. And so this gives you a little bit of a checklist. So how do you start to think about study design? And anyone who's gone through any epidemiology training will remember this from their training. This is important for individuals and helps us assess. And I think one of the things that we've sort of learned through the process is, we had an intensive stakeholder engagement. We really wanted this to be the foundation, and now we build on that foundation to start to think about what is the rationale for using certain tools and what is the rationale if a submitter is giving us a cohort study, but we were really expecting to see a case control. We can at least have some language around what that looks like. And really, because we wanted to harmonize internationally, this is our guidance document that allows us to do that. And then I mentioned our post-market drug evaluation program. We have a very time-limited task force that looks at real-world data and post-market evaluations, and really to build on the reporting to now build on how do we answer these decision-maker questions for all of us along the way. And maybe the last thing, one of the last few slides, Canada's National Strategy for Drugs for Rare Diseases. The Canadian government is really interested in improving access for affordable and effective drugs for rare diseases, and has provided funding for not only our organization, but for the provinces and the territories to help support the implementation and access to real-world evidence. And then as part of that national strategy, there's work going on to look at different kinds of data sets. So in order to understand how well these diseases are working, and if robust clinical trials are not available, other sources of data may be registries. And we have a registry program where we're actually working with registry owners to actually bolster or improve the types of data that they're collecting. So remember, for registries, we don't know if they've consented patients. We don't know if they are allowed to share the data. We don't know if they have the right outcomes. We don't know if it's being objective or subjective measurements of clinical evaluations. And so part of this work is not only to improve or think about certain registries and increase the quality of those registries, and at the same time we're establishing national standards for registries, again in the same way that we worked on guidance for real world evidence, but also harmonizing it with international spaces and then testing out the registries themselves. And maybe just the last couple things, lots of international collaboration. This is a global report that we were involved in, talking about evidence and using it in decision making, and really trying to ensure that we're all using the same language, we have the same expectations. We may have different appraisals, but at least we're looking at it in a standard way. And I think maybe the last slide is actually my last slide, but these are opportunities for us to think about validating outcomes, especially if you have surrogate outcomes in a clinical trial space. How do we incorporate evidence into health economic models, or if we have time-limited approvals of particular drugs, how and when and what kind of outcomes do we look at to validate the particular outcomes and to ensure that we've actually made the right kinds of decisions? What evidence do we use? And then often the world moves automatically from real world evidence to outcomes-based agreements. And you can't have outcomes unless you have data, and you can't have data unless you actually think about moving into the real world evidence space. So I think that that's really all I wanted to highlight. Thank you very much. And I look forward to any questions or in the panel. Thank you.
네, 여러분 큰 박수
A big round of applause, please. Thank you, Dr. Bittman. We'll move right through the panel discussion.
토론을 위해서 잠시
So we will arrange the seatings for the panel discussion. And first of all, we heard from Dr. Bor-Sheng. He mentioned about ICA and DAA as some cases of treatment that used real-world data. And he also gave us a lot of food for thought for our discussion. We will hear from him in a short while during the panel discussion.
좀 소개해 주셨는데 이 데이터에
And also, Dr. Nicole told us about cases in Canada, as well as some monitoring methods, and she also finished off with regards to the importance of international collaboration. So in a short while, we will have the panel discussion after the seats are arranged. And for the panel discussion, we have our moderator here with us. We will have Mr. Yoon-Soo Park, the chair of the Subcommittee for Economic Feasibility Evaluation of HIRA, moderate the panel discussion. We will hear from him in a very short while. After this panel discussion, we will have a short recess. And the second session is also comprised of 2 presentations and another panel discussion. Now, our former 2 presenters have given us insightful presentations. Unfortunately, we are quite short on time, so please be mindful of the time. And now I think we are ready to introduce our moderator, Mr. Park Yoon-soo, the chair of the Subcommittee for Economic Feasibility Evaluation of HIRA, to the stage. Please welcome him with a big round of applause.
고맙습니다.
Thank you very much. Next, let me introduce our panel list.
Please be seated on the stage. 네, 제가 소개를 드리겠습니다.
So let me introduce them one by one. We have Mr. Tok Hyun Yoon, the Associate Professor of Oncology of Seoul at the Medical Center. We have Ms. Euna Han, the Professor of College of Pharmacy of Yonsei University. We also have our keynote speaker, Director General Lee So-young Lee of Health Insurance Review and Assessment Research Department, HIRA. And also we have, of course, our presenter, Professor Bor-Sheng of the National Taiwan University Cancer Center. And we have Ms. Nicole Mittman, the Vice President of Canada's Drug Agency, who will also join us for the panel discussion. So now let me hand over the mic to our moderator. But before that, please greet them once again with a big round of applause. Hello. I am the chair of the Subcommittee for Economic Feasibility Evaluation of HIRA. I am Park Gyun-soo. It's an honor to be here with all of you today. So for the first session panel discussion, let me get started right away. So we have 5 panelists here with us for the discussion. And we are joined by our speakers, Bor-Sheng Ko, Ms. Mittman, as well as Director General Lee So-young, as well as 2 other panelists, Mr. Yoon Duk-hyun and Ms. Han-euna. Mr. Yoon Duk-hyun is the Associate Professor of Oncology of Seoul Asan Medical Center, and Ms. Han-euna is the Professor of College of Pharmacy of Yonsei University. So we have 2 presenters here. And for the 2 panelists, they will briefly give us their own presentations, and after their presentation, we will have a discussion. So first, we will hear from Professor Han-euna.
Hello, everyone. My name is Tok Hyun Yoon. I am Associate Professor of Oncology of Seoul and Asan Medical Center. So I will share my brief thoughts on the topic of the symposium today. My first thought was that it's about time. We had a lot of discussions earlier in the morning and the afternoon. We are seeing the increasing deployment of innovative drugs and technologies, which is welcoming, but they are priced very high. So the question now goes, how can patients benefit from these new prices and these new drugs and technologies through reimbursement? I am one of the taxpayers, and I'm also enrolled in national health insurance. That's why I also came to think about this very question. I also am a doctor who sees and meets a range of patients in the field as well. So I have mixed perspectives in that regard. As a doctor in the field, how fast can the new drugs be accessed from patients' perspective? How can they be approved fast for reimbursement? And how can they be applied in a more broader scope? So those are the questions that I have to ask as a doctor. A complicated and complex process for approval and also discussions and negotiations for pricing are necessary. However, even new drugs that went through large-scale RCTs, they often have limitations in real-world application. That's why RWD and RWE are very important, and there's no doubt about that. In my opinion, the application of RWE can vary, but for anti-cancer drugs in the EU and the US, if you look at Europe and US, anti-cancer drugs often go through single-arm studies. That's why, in that regard, RWE can be very beneficial. Also, not only new drugs, when it comes to lymphoma, there's a specific type of lymphoma that's pretty rare, and there's this outcome. There's this existing agreement that this particular drug was not effective for the drug. But then there was an evidence that was contrary to the existing belief in the U.S. That's why the drug that was previously thought to be ineffective became a standardized treatment in the U.S. So in my opinion, real-world evidence can be beneficial in finding new indications that were previously not found in clinical trials. And also, real-world evidence is beneficial in proving efficacy of marketed drugs. Real efficacy. So these are the points that I agree about real-world evidence and why it's important. But at the same time, I think we need a calibrated approach. Earlier in the morning, Professor Yi talked about some clinical trials and how it's different and how the result is different in Korea. We saw 40% when it comes to eco-performance, which is very different from the clinical trial result, but that's the real world. Why is real-world result in Korea very different from clinical trials? No matter how effective a drug is, it's not going to work for everyone. So any drug needs to be used to relevant patient in a relevant way. So we need to adopt the process that were mentioned in the presentations to make sure that we get faster access to patients. But during the process, we need to consider that real-world evidence is different from clinical trials. Like Professor Yi said, how are we going to compare 0-1 to pivotal population? When we set the goal, we have to set the goal that reflects on the fact that we're using real-world evidence. Also, secondly, there are challenges associated with collecting real-world evidence, like Dr. Meatman said just now. We need a very complex system. I participated in a project to collect 800 patient data for mantle cell lymphoma in APAC. This was collecting data about patients who went through treatments. However, it took me 2 years to collect 800 patients. So if we were to collect real-world evidence, how are we going to approach it so that it's more efficient? So those are the questions that we need to consider. Thank you. Dr. Han, please.
Okay, hi. I am from the College of Pharmacy of Yonsei University. I am Han Eun-ah. So let me refer to my notes. So first, let me touch upon these international implications for utilizing RWD and E, and then let me go into the domestic aspect. I think that to utilize RWD and RWE, it's important to have registry, and RWD is just as important as RCT. I think that's not up for debate. And in Korea, there has been ongoing study regarding RWD for a couple of years, and a lot of people here are involved in related research projects. So when it comes to RWD, It's regarding all of the life cycle of a drug from pre-approval process, approval process to the reimbursement process and the management after the reimbursement listing. So if we deem that RWD is utilizable, then it can be used in a variety of cases, as we have heard from the two presenters. For Taiwan, we heard that there are some treatments that are applicable for reimbursement based on RWD, and also the government is running a registry actively, and also payers can utilize a lot of the registry that is being, or the data in hospitals. So basically, the Taiwan government is currently actively making effort to use a lot of the data that exists in hospitals. And regarding Canada, we heard that they're trying to use existing registry, and also they're trying to develop a national registry as well as a national standard. So we heard about how active the efforts were ongoing in Canada as well. So that is what we heard. And we also heard from UK in the keynote speech in the morning. And also she mentioned Denmark as well. And I think that these global cases all have similarities. I think that it's important to have a government level guideline to coordinate efforts in facilitating use of RWD. Then what implications do these cases have for Korea? First of all, I mentioned how RWD is utilizable in all life cycles of a drug. If RWD is of high quality. But right now the problem is that we have limited registry. So when it comes to regulations regarding registry and reimbursement decisions, I think that we need to think about whether we can have a registry as a default setting, but I think that that is not realistically feasible. So I think that HIRA, therefore, is considering using registry for things like RDD, rare disease drugs, for cases where it's difficult to get a population for a clinical trial, and for very high-priced drugs. So for drugs that are hard to get evidence and drugs that can get evidence but have high budget burden. So I think HIRA is thinking of measures to add on registries for these limited drugs. And if we do that, and if we do try to make use of that registry, I think that we need to think about the premise and the result of that registry. I think that the registry should be as effective as RCT. Basically, it should be as relevant, reliable, and transparent as RCT. If we have a registry that is just like that, then I think we could have a representative registry and also utilize RWE from that registry. And if that registry is just as effective, I think everybody would be for using that registry. So a lot of you said best approach. And I'll just keep on using registry instead of RWD. So in running registry, what is important? How can we extract evidence from registry? So how can we really get evidence for drugs that have limited evidence, such as rare disease drugs, as well as high-priced drugs that have a lot of evidence, that have a lot of uncertainties. So drugs that are very expensive and that need to have tracked performance. So I think HIRA prepared today's symposium with great interest in the matter. Who is going to take on this role then? I think that the public, so the government, should be leading the efforts of creating this registry. Then who is going to lead the efforts? What agency? There's a lot of agencies out there, right? There's going to be agencies that take care of reimbursement and agencies that take care of registry. Now for Korea, all of these agencies are divided for registry as well as for reimbursement. So we can think of SRTR for the US, and there's similar public registries for the UK, and all of these registries actually are publicly funded. and they're managed publicly. So I think that Korea should take a similar approach, and I think that this registry should be public because one registry really is not perfect. I think that the great claims data that HIRA has is even limited in itself. So I think that we should really align with other agencies out there to create a more complete RWE. And to align such data, we have to overcome the barrier of privacy protection. So I think that without the efforts of the government, we cannot make this complete, comprehensive registry possible. Then who is going to be the stakeholder that is going to be in charge of creating this registry? Like I said, the government should be in charge. And what kind of agency, what kind of governmental agency should be in charge? I think that we can think of an intergovernmental agency, which sounds very grand, and we will have to discuss and go more into depth about how to make this more concrete and applicable. So I said that the most ideal conclusion would be to have a registry as good as RCT. I think that if the registry's quality is as high as that of RCT, nobody would debate against or be against using registry. For those of you that you use observational data, I think you would all know how it's difficult to have such a complete level of registry, which is why alignment and collaboration is more important than ever. So then what should the government do? We need a standard. Just like we heard from Canada's case, I think HIRA is making efforts to set up a standard or a regulation, whichever government agency is involved. I mean, right now in Korea, there's a lot of different agencies involved. The Ministry of Food and Drug Safety is also involved in the matter. And also the reimbursement agency is discussing ways to make this registry more transparent. So this is all from me. Thank you very much.
네, 감사합니다.
Thank you so much. So, according to Professor Han, it all boils down to the people and, the resources, the monetary resources. So we have 5 panelists here. So if you have any questions to these 5 people here, please feel free to ask.
네, 잠시만 기다려
Please hold for a moment until we bring the mic to you. Can you stand up if you don't mind? Thank you so much.
잠시만 기다려 주시면.
One moment, please. Mic is on the way.
네, 안녕하십니까. 저는
Hello, my name is Ji Hae-byun from HIRA. Thank you so much, everyone, for joining us from afar. Thank you so much for your presentation as well. Since we work at HIRA, a lot of the issues are shared by us as well, and I have a few questions regarding those. To Dr. Bor-Sheng, in collecting real-world data, academia collects it and then it's sent to healthcare institutions, and they send it to government. But then, shouldn't we collect it from healthcare institutions to begin with? Can you provide more specifics about the process? And my next question goes to Dr. Meatman from CDA. From your presentation, you mentioned FDA's expanded use of RWE in approval. I think that's becoming a global trend. Previously, our understanding is that RWE complements RCT, but in case of FDA or other approval regulatory institutions, if they're actively using RWE, then how should we view RWE going forward? And if the drugs, for example, are approved through such process, is RWE excluded after that? So those are my questions. Thank you.
Thank you for your questions. The first, I'd like to clarify if you are asking the data transfer from the academia side to the insurance. Okay, and actually in Taiwan, the government, the insurance actually is belong to the government. And when the insurance, when the hospital join the insurance, they need to have a contract with the government. And the contract will include those kind of information need to be transferred. And the second is that the legal framework inside or in Taiwan actually allow that the data can be transferred without with the exemption of the privacy, if the data should be used in public utilization. And the government is responsible for the privacy, and the government should protect the privacy when the data was sent to the hospital, when sent to the insurance. So under such a legal framework, and also with the contract between the academia, the hospital, and the insurance, the data can be transferred under the protection of the law in Taiwan. So it's okay. And so if the insurance say that if you don't submit the data, I will not pay you the cost, then the hospital need to submit the data. And we also have some example, for example, for CAR-T and for the immune checkpoint inhibitor. If the government found that the hospital did not submit the data after 3 to 4 months claim for the drug or the price, the drug, then the government will ask the hospital to refund the cost to the insurance. So let's ensure the government can let the hospital to submit the data to the insurance. Is that okay for you?
Thank you. And the 민만 교수님. 네.
I'm here.
Yeah.
Thank you. I actually liked Professor Koh's question better, and maybe what I could also add, and then I will answer the FDA question. Our registries, and one of the reasons our government is starting to invest in registries, is they are funded differently, and the mandate is often different, especially for rare diseases. Sometimes they are funded by industry, sometimes they are government funded, sometimes they are academic funded through grants. Other times it is a small patient group that is organizing because they want a network of patients with like-minded diseases. And so the challenge is all of those registries are created unequally and differently. And so hence the reason why we're trying to increase the quality by having standards and ensuring that once we have those standards, then we can use those registries, as is the ultimate goal, to help inform decision making. So I wanted to add that in. It is even more complicated in other countries. And then how do we share, and how do we get it from an academic desktop through privacy rules to go into a standard or a standardized server, for example. The FDA question is an interesting one for us. I think what you asked is, if RWA is going to be used for decision making instead of on its own, instead of complementary. And I think what the FDA has done is, in order to use real-world evidence in submissions, the evidence had to meet some sort of criteria, and it had to be part of, is it part of the submission? What is the role in the study? So is it because you didn't have an adequate or adequate clinical trial, or it was ethically unfeasible to conduct that clinical trial? So it's not just a replacement, but there has to be some criteria around it. And is it actually collecting the right kind of endpoints? And I think that's sort of where we are starting to think about it as complementary, and are they all moving in the same direction? So if you have some sort of clinical trial data and then you add in real world evidence data, are the outcomes moving in the same direction? And often that increases the certainty of the use. But I do think that the FDA is not yet ready to only accept submissions. It has only been in combination with real world evidence, but there will be more and more of those kinds of submissions. And I think even for broadening indications, there is an opportunity to look at real world evidence. And the example I might bring to the discussion would be, for example, a clinical trial is conducted in an adult population, and yet we want to use it for pediatrics. And we have a number of examples at our organization where the clinical trial was conducted in a 18-year plus cohort of individuals as inclusion criteria, yet the drug itself has become or will become standard of practice in the pediatric population, and yet we don't have a regulatory approved trial. And so as we have set up a separate program called our Formulary Management Expert Committee, where clinicians can actually submit data and ask for an assessment of a broader indication around the technology, where we know that the manufacturer will not conduct, for example, another trial in a pediatric population, or it's not feasible or not ethically correct because it has already been shown to work in an adult population. So in those situations are real opportunities for real world evidence as well.
Yeah.
Any more questions from the floor? Thank you so much for the wonderful presentations and insightful remarks. I am Yeo-Dong-Ho from LG Chem. I have a question to Dr. Bor-Sheng.
교수님께서는 연구자.
So you're a researcher, Dr. Bor-Sheng, and also you belong as a co-chair of the Expert Advisory Committee of a governmental body, NHIA. So I think that you have two different perspectives when you make this decision. So I think that there might be a bit of a conflict of interest when you make decisions in the perspective of a researcher and also as a co-chair of NHIA. So how do you persuade people you work with as a person with these two perspectives? And also,
네.
I have a question to Dr. Mittman as well. I heard from your presentation there is an industry task force that your agency established. When it comes to post-market evaluation, is industry task force involved? And if so, how? And is it still ongoing? And how do you partner with pharmaceutical companies in implementing such guidelines? And how do you continue to communicate with them and then update them?
Tough question to act as two roles. And I usually, in the beginning, I usually feel actually I have multiple personalities actually. Okay, but I think as a physician or researcher, and another role is act as reviewers in the reimbursement committee. Actually, I must say that we must divide the primary interest versus secondary interest in these two roles. In the review committee, I think the primary interest it would be the health for all patients, for all population, not the benefit for single patient. But as a physician, I think the role is different. We must determine the benefit for single patient, not the overall population. So actually, the first is that I will try to divide the person's or friend into two groups. One is more belong to the researcher and one is more belong to the reviewer. But I think the second part is that actually the two roles actually will benefit to each other. Because as a reviewer, we must know the exactly what happened on the first line in the medical care. And as a reviewer, I think, and as a physician, I think we must know what's the difficulties in the situation in the national reimbursement and the financial issues. So actually, as a president of the Hematology Society, actually now I think I was trying to bring all these two together into more transparent discussion to let the physician know that what we are facing for the overall situation in not only in single patient, but also even not only in the hematology or oncology, but also for all kind of the patient. And let the government and the reviewer committee to know that what's the problems in the individual care. I think I'm trying to initially two roles, and I'm now trying to merge them together. Okay, thank you.
Please, Dr. Minman, please.
Yes, thank you. And maybe I can start with saying that I am a frustrated health services researcher, and the opportunity to bring in, I'm coming not from the clinical perspective, but I come from the database perspective. So working in that space for 30 years, knowing that we can do it, but we need processes and confidence in place in order to use it in a consistent way. The question asked about the industry task force, this is actually a time-limited task force, really to identify opportunities and barriers for industry who are using real-world evidence and to support some of our post-market drug evaluation program. And industry, are often generators of real-world evidence and data, and or supporters of real-world data and evidence, and or conduct some of the analytics. And so, and yet they sometimes don't hold the data and need access to existing data sets. So part of this industry task force was really to understand how to be much more efficient in making sure that we have the right data to review at the right time, and really to allow the technology to have the best foot forward. We want to give it the best chance and ensure that we're looking at the right kind of evidence. I think the other part is this, if we don't include industry, the generators, the supporters, the submitters, I think we miss part of that perspective in our own analyses. So we listen with an open ear about opportunities or how do we move forward, and that is actually one of the reasons this task force was one of the reasons we started our early scientific advice program for real-world evidence, where we could all work collectively to answer questions about what kind of outcomes are the most appropriate outcomes to patients, to clinicians, to payers. It also helps answer or address, are there existing data sets and or registries that are out there that we could leverage? Or perhaps maybe they have 80% of the data, and how do we support them to get 100% of the data required? It also brings everybody together at a table where we can collectively agree on one or two or three of the outcomes that allows us then to do that kind of analysis. So for example, we would have databases that would look at health system encounters, emergency room visits, hospitalization. We have other databases that look at drug utilization. So how do we merge those together? And then how do we bring in the academic community too to help ensure that we're using the most robust methods? So I would answer that to say that we have a multi-stakeholder approach to thinking about evidence in the real world, and how do we use that evidence and find it or enhance it or refresh it or link it in order to answer those particular questions. And industry is a part of that conversation.
네, 감사합니다.
Thank you so much. We are engaged in an active discussion, but we are having a little bit of a delay, so let's wrap the panel discussion. So if you have further questions, please continue during the break. So we'll wrap the first panel discussion of the session 1. Thank you, everyone. Thank you, everyone. Thank you for the enriching discussion. Unfortunately, we are experiencing a little bit of a delay in the entire program, so apologies for having to wrap it up a little early. So we'll have a short break for 10 minutes and we will resume session 2. Coffee is ready outside, so please be seated by 3:10. Thank you very much.
Gentlemen, we will have a short coffee break. We do have some coffee in the lobby. Please enjoy them. This break will be about 10 minutes and our last session will begin about 3:10. Thank you very much for your kind cooperation.
Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. It fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services so that it could contribute to enhancing health and social security for the people. Some people say we are quite stubborn and strict. However, there are solid principles that we must stick to, no matter how hard it is. Fairness to save the health and safety of the people. Trust to establish quality healthcare system for everyone. Expertise to accelerate Korea's healthcare system and to take the lead in highly advanced medical environment. And connectivity through consistent cooperation and communication with the people and stakeholders. We will navigate ourselves to the destination we set by the 4 principles, no matter what it is. As we gather years of experiences and know-hows, and as the people and hospitals expect more from us, we naturally push ourselves toward a higher standard. We've never been afraid of taking on challenging risks. Long before the global shift towards digital transformation, we were already harnessing the power of our advanced ICT system to collect healthcare data. This seamlessly interconnected data plays a pivotal role in our daily operations and regenerates new value-added information. This concerted effort contributes significantly to delivering enhanced healthcare services for the benefit of the people. The essence of HIRA is reflected in its commitment to review and assessment. We objectively and fairly evaluate service claims submitted by providers to ensure that they align with our legal criteria and requirements. This ensures that health insurance premiums are maximally utilized for the benefit of the people. Additionally, we assess hospitals to determine if they deliver the most effective medical services from the patient's perspectives. We share these results with the public, contributing to the elevation of healthcare quality. Another responsibility of HIRA involves establishing the benefit criteria covered by the National Health Insurance. We define and monitor the suitability of benefit criteria for both providers and patients by regularly and incrementally updating reimbursable health services. Moreover, we assess whether to list new health products and technologies in the benefit package. This helps ease the financial burden on patients and enhances healthcare accessibility. We enhance the accuracy of claim reviews and quality assessments through Integrated Healthcare Resource Portal. This portal serves as a platform through which hospitals share essential data, including information about human resources, facilities, and equipment. The Drug Utilization Review is a real-time solution that provides doctors and pharmacists with vital drug information during the prescription and dispensing processes to ensure patient safety. This service safeguards the health and safety of individuals by conducting pre-checks on potentially unsafe drugs and ultimately preventing patients from taking such medications. Pharmaceutical Information System plays a pivotal role in patient safety as well. We serve as the command center throughout the entire drug distribution process, spanning from production to supply. This contributes to a transparent and well-managed pharmaceutical distribution system. To predict any possible diseases in the future and revitalize the current medical industry, we are making healthcare big data accessible to academia, medical communities, industries, and the public. As a specialized organization in claim review and quality assessment, we have been actively collaborating with countries around the world in terms of R&D and healthcare projects to create and provide quality healthcare information to the public. We believe that our unwavering and continuous efforts will secure a future of healthcare services for the people. We take full responsibility for public health and safety, thoroughly understanding all aspects by taking the closest look and the deepest dive into them. We offer a range of systems and services, prioritizing people's right to information and valuing them as health service consumers. We provide a service that allows patients to verify whether the health services they received are covered or not. Furthermore, we make non-reimbursable health service items accessible to patients for their informed and reasonable decisions. We require hospitals to clarify uncovered health services to their patients before consultation. We also allow people to easily access to health-related information on their mobile phone. The Medication History Verification Service stands out as a remarkable public service. Through this service, patients can track the medicines they have taken in real time. It operates by utilizing pharmaceutical information collected during the prescription and dispensing process. Drug Information Provision Service is another public service that enables patients to easily check details like expiration dates and warnings by scanning the barcode with their mobile phones. We also offer a top-rated hospital finder service, making it easy for people to find the hospitals they most need, right in their neighborhood. We are promoting and extending various services so that everyone can enjoy more prosperous health services. HIRA has always been with the people, even in an unprecedented national crisis like COVID-19. As a lead healthcare institution, HIRA supported the pandemic response at the entire process with state-of-the-art ICT capacities, advanced human resources, and materials. We also have led by example in promoting the best practices of our quarantine policies and healthcare services that played a significant role in response to the pandemic. In particular, we raised the national status and competitiveness by exporting Korea's healthcare system to Bahrain and providing tailored healthcare policy consultation to many countries. There is a reason that we stick to our principle more stubbornly than anyone else, because we know the potential and power behind the commitment and perseverance to uphold the basics. We believe that today's principles become a driving force of tomorrow. With this belief, we're dedicated to shaping an advanced healthcare environment where everyone can enjoy health and happiness. Medical service and health insurance are closely connected to people as well as to their lives. Since the moment that health insurance has been with you under the name of medical insurance, reviewing medical expenses has always been an issue. As medical insurance universally covers the whole population and the National Health Insurance Act is enacted, medical insurance claims had to be reviewed in a fairer, more professional, further unbiased manner. It fueled the great necessity by everyone for independent review organization, which is the Health Insurance Review and Assessment Service. HIRA is authorized for the fair review of medical claims and the assessment of healthcare quality. HIRA is striving to release the burden of medical expenses to provide safe and quality healthcare services so that it could contribute to enhancing health and social security for the people.
I think most of you are seated. I hope that all of our online participants are ready as well. Now let's move on to our very last session. We have 2 presentations as well as a panel discussion prepared for all of you. Please stay with us until the very end of the session. So the first presenter is going to be Professor Jatin K. Dave, Professor of UMass Chan Medical School. He is going to be presenting on balanced approach to pharmaceutical coverage, focusing on outcome-based contracting and real-world data.
이라는 내용도 오늘 자세하게 전해주신다고.
Professor serves in Mass Health and UMass Chan Medical School for Health Consulting and also is overseeing healthcare services for the Massachusetts Medicaid program. He is here with us offline, so please join me in welcoming him with a big round of applause.
The stage, and ladies and gentlemen, let's welcome him with a big round of applause. 그럼 박수로 모시겠습니다.
안녕하세요. It's about
감사합니다. 지금 보스턴에는 새벽 2시 반이거든요. 그런데 지금
I want to thank the HIRA leadership, starting with the President Kang, Director Han, Director Yi, Dr. Oh, Dr. Jung, all of these directors as well. I came to HIRA in May. I actually came to the NHIS Global Summit in May, and I requested to visit HIRA because I really admire the way HIRA operates and sets up the rates. So I really wanted to learn from Dr. Yi and other people, which is how I got a chance to meet them, and then I'm here invited to speak with you. My role is focusing in a state of Massachusetts, which is on the eastern side of the US, where we take care of about 2 million welfare members in that state with about $20 billion budget. My role is to lead our clinical team of physicians, pharmacists, nurses, and so on. The focus today, as you heard, would be on the pharmaceutical coverage. And I think this is a really, really important conversation. Once again, I want to really applaud your efforts because I don't think I've been to the 2 global conversation in 1 year in my entire life, except in Seoul. The way you are learning from all different countries and all different systems tells you a lot about how amazing your culture is. Your humility, your hospitality, and intellectual curiosity is completely unparalleled to what I've seen anywhere else. So just want to thank you for all that. I also want to thank our pharmacy team who does a lot of work, and I take a lot of credit for it, but they are the one who are really doing the work. You will see here Neha and some of the other team members in a few minutes who does really, really hard work. You will see at the end of my talk, but there's a team of about 15 people. It's a small but mighty team which saves about $400 to $500 million per year for our state, just between that team. And one of the pharmaceutical industry person was joking about it, saying, if you are smart enough, we'll just give you $50 million and keep those people at home so they never have to come to work, and we will have a pretty high return. The theme of my talk, as you heard, is on balance. So let me move to the next few minutes, and I want to make sure I'm staying on time. So I'll try to finish up around 3:45 sharp, so that you all can hopefully get home on time. The reason why this balance is so important is I think we are trying to balance the access of these amazing innovations with cost and sustainable future for all of us, which is going to be really, really important. So I will start with a very high-level global view on what are the global opportunities and challenges. And honestly, the problems are pretty similar, no matter what country you are talking about. The solutions are not the same, by the way. So I would strongly urge you to not look at any of our solutions and think about you can apply it here. One thing which I've learned is solutions are so local, because even in our amazing country, our state has a solutions which doesn't work for other states. Forget about bringing it over here. So the problems are very similar. The solutions are very different depending on your local realities. My next few minutes, I'll focus on the outcome-based contracting in the US using the real-world evidence. And then I will dive into the framework we use at our institution, at our state. We have been at this for about 6-7 years now, with about a dozen contracts or 10 contracts currently, and learning a lot about this, and then summarize what we have learned so far. And happy to have an offline conversation with any one of you any time if you want to learn more about any of these topics. So opportunities and challenges. As you heard from pretty much all the speakers, the innovations are truly amazing. So just focus on the left side of the part here for one more minute, just to make sure we don't undermine this. This is an exciting time to be in the healthcare field and pharmaceutical world in general. Traditionally, when I was getting trained about 25 years ago, there were a lot of Me Too drugs, right? Drugs which are very similar. Versus now, as you see the really novel drugs with amazing impact. So if you're a parent of a child with a rare disease, this is such a hopeful time for us to be in this time of the world. Totally understand the cost issues and sustainability issues and the budgetary issues, but at the same time, we should never undermine how exciting this is and how pharma industry is delivering beyond our expectations to cure some of these diseases. Even the treatment for obesity, the impact of those drugs are marvelous, no matter how you look at it. So I want to make sure, before we dive into the negative aspect of this, make sure we recognize the positive aspect of this first. Now coming to the negative part. The important part is the list price right here. The list price of the drugs which are approved in 2023 was $300,000 compared to $2,100 in 2008. That 141 times increase. 141 times. Not percentages, 141 times. Just think about that for a minute. So, amazing intervention, unaffordable prices. We need to balance those two things in some ways. Again, just to make sure you don't try to feel like we are trying to share with you what US is doing amazing, you are doing some amazing work here. By any means you look at it, your system is way better than our system. Our state, just to brag about it for a minute and just to recognize where we are really good, is typically number 1 or 2 health status in the whole country. And I really want our state to compare it to you and other countries like you, rather than other parts of the US. Because yeah, we are doing pretty well in US, but we still have a long way to go to learn from you and manage things better. So in US, as you see, there are probably about 342 million people. You see that we are a little bit younger than you. The life expectancy is a massive difference between Korea and US. Infant mortality, much better here. The cost, even though it may seem like a challenge here, we have a much bigger challenge compared to you, almost 3 times. And then overarching GDP continues to remain a challenge for us. And the drug expenditure is also similarly, as you see here, a massive difference. The interesting part is the GDP of drug expenses is very similar, just to point out. The utilization of the drugs is much higher in Korea per person than US, just to make sure you make a note of that. You also see your doctors more frequently than in US also. So traditionally, just a quick review of what we do. So our traditional levers were all focusing on generic substitution. And by the way, US and our system does a really good job at this. So we have kind of optimized this maybe about 5 years ago, where there's not much for us to squeeze on the generic substitution. Internationally, that is not the case. Then you come to the formulary. Whatever you want to call it, whether it's formulary and step therapy, preferred, not preferred list, positive, negative list, we are talking about the same thing. We are talking about a preferred list of some sort by which you give a preference to a particular drug over the other drug, either through step therapy or other menus. And that part has also been pretty much optimized in US as well. So not much left there to do. So then we moved into rebates and discounts. And by the way, US system is one of the most complex and difficult to follow system. If you ever want to see the graphs of how many stakeholders are involved and middlemen are involved, it will drive you crazy. But it's a pretty logical system once you understand the different players and so on. And then this is where we focus on over the last 6 or 7 years. We are one of the very few states where we do have an authority to negotiate directly with the manufacturers the price of the drug, and we have a pretty strong levers to help manage that part. Lastly, then we move into kind of reference pricing, which is not feasible in US right now. So that is not an option for us right now. We are starting with the price transparency and some of the other things through the Inflation Reduction Act over the last few years. And you probably saw the prices for the 10 top drugs just got announced. In case you want to see what the US prices are, you will see the real prices for the first time, which was just announced like 2 weeks ago. And then the value-based contracting, this is where some of the real-world evidence part comes into picture. So how do you keep on doing this? In US, we don't have a perfect system, but one thing which we keep on doing is we keep on experimenting. We keep on trying different things and keep on failing at times, but we still keep on trying. That's probably one thing good about our country. And then the new models, as you see, the outcome-based contracting model are probably the one thing which you might have heard about. We are beginning to touch some of the subscription models, and then a lot of states are trying this prescription drug affordability board, which is one way for us to control the drugs. I will come back to this in a minute, but as a state Medicaid agency, we don't have too much control over not covering drugs. There are very few drugs which we cannot cover, like the obesity drugs. Yes, we do have an option of covering versus not covering. Once the pharmaceutical manufacturer accepts the rebates from federal government, all the state Medicaid agency must cover those drugs. We can put some controls, but we have to cover those drugs. So coverage is not optional for us. And that's why the other levers becomes really, really important, especially the price, as you will see in a minute. So US landscape, you saw this graph before as well. The expectation is the specialty drugs will continue to increase, almost doubled in last 5 years. So more drugs, more costly drugs, more specialty drugs, and as you will see over here, there are a large number of these drugs coming out as well. As you see, typically there are about maybe 20 to 30 drugs being approved. Last year, the approval rates has become higher and higher to around 55 drugs. And they're approving drugs with limited evidence to make sure there are access to these rare diseases and orphan drugs, in a nutshell as well. You've seen the accelerated pathways, which I would not go into the details of, but the bottom line is there are a lot of new novel drugs coming in an unprecedented way compared to before. About half of the drugs are drugs which are novel drugs for rare diseases which are being approved. So it's like a triple whammy. We are getting a challenge in three ways. High cost drugs, more specialty drugs, and coming faster and faster is the message. The other part you will see is the FDA is also approving a lot of drugs with surrogate endpoints. The biggest example being Alzheimer's disease drugs, which were approved with biomarkers only without having any clinical benefits earlier in a nutshell as well. The one thing which I also want to mention about is I think the challenge is going to be somewhat different for single curative treatment plan versus things like obesity and Alzheimer's disease, where the drugs are going to continue with a pretty high prevalence of those conditions. So it will require a very different approach for drugs like for Alzheimer's disease and obesity versus sickle cell disease or thalassemia or some of the oncology drugs. That's another thing to keep in mind. So I'll skip through the expedited approval process just to stay on time, but basically the intention is really good with the accelerated approvals. However, what that leaves you as a payer is to make sure you are at times required to fund some of these drugs to collect the evidence on these drugs, which is not something which we are typically staffed or funded to do so. In the US, this value-based care journey is what we have been at it, and again, I would not review the whole thing, but the main thing which you see is this accountable care models where we are shifting more and more risk to the provider community is what our overarching mindset has been. And there is a institution for the clinical and economics research, ICER, which is based in Boston, by the way, which does a lot of good work, which was also created about 10 years ago. So the journey on value-based care is initially, as you know, we were all kind of sick and tired of getting paid for fee for service and working like a hamster to just churn more patients, to paying for quality, to now paying more for value has been our journey over the last few years. The value-based contract numbers, you will see this is the older data. The numbers have increased slightly, but by different payers. In case you want to see, here is what the reality is. They're really small numbers. I think our state is probably the state with the most value-based contracts out of all. But overarchingly, the payers are, again, even the bigger payers, as you see over here, like Humana, 2 value-based contracts. This is not a significant number, unfortunately. So I think we are still an early adapter or a kind of pioneer in this particular field. In case you want to learn more about why we need to cover medications, here are more details. So basically, once the drug company accepts the rebate, Medicaid must provide coverage. We can put some controls, but we have to provide coverage. And then the rebates amounts are listed here, which I would not go into the details of, but you can read through this in case you are curious. And then this is by the way, what we call federal rebates. And then on top of that, we can negotiate additional rebates for which we need to have additional authority from our state, which is what we are negotiated for. So this is the last part, is the new part. This is kind of more standard federal rebates. Excuse me. The contracting options, I think Dr. Yi kind of covered this, but basically there are a few ways to kind of think about this. One is you come up with a non-performance-based arrangements. you can look at the individual performance-based arrangements, and then you can again look at the different options, as well as a kind of conditional coverage with evidence development if you want to. And we have done some part of all of this. In case I do forget to mention this, we also ventured into covering the digital therapeutics, the digital apps for substance abuse disorder earlier as well, and put a good framework for covering that, which I did not put in this slide deck, but in case you are curious on how did we approach that, there was also an outcome-based contract, which we ended up putting in place. Another exciting thing for us to focus on is I really think the technology is at the tipping point. The way we are currently using data is really unfortunate and awful. I was reflecting on how best to describe this. In US, with Tesla, if you hit a bigger bump, I saw this in real life at Tesla company, they get a notice in real time that one car hit a real bump in that car. Within few minutes, the next car comes in, the car automatically slows down if you're auto driving. So this kind of real-time input is not imaginative anymore with technological advancement. It's happening in other industries. We must learn and think outside the box to do that, basically. And I think we are almost there with some of this. And I would not describe the details on here, but I think some of the data repositories which are being created will definitely move further advance. And the computational power is increasing so fast that some of this is really, really happening, which I know sounded like a fantasy a few years ago. So framework, we go through an annual process. This is kind of our internal process. We have kind of 4 steps. So we typically prioritize annually what drugs do we want to focus on to negotiate the prices on. Neha and her team, and Neha leads this team, starts with the meeting with the manufacturers. They try to start with the clinical presentations, then focus on the drugs that meet clinical thresholds, and then they review the authorities and explain the templates to the manufacturers. Next, we assess the value, and you can see the key steps in value assessment, which is all kind of evidence-based and evidence-driven. Then we start negotiating, and this is called best and final offer. If we don't agree on the negotiation process, then we do have a lever to go through a public process by which we put the manufacturer in front of a quasi-experimental agency called Health Policy Commission. No manufacturer has gone through this. We've been very close to being there, but every time we try to meet with the manufacturer and go through a public process, they usually have come up with a pretty reasonable offer, which we have been accepting. So it's one of the most powerful but never used regulations in our state. And then the key part is this part. And this is where you heard there are a lot of challenges. I'm so proud of our team, which has done a great job in operationalizing many of these contracts, because these things are, the way the data is currently structured and to ingest and analyze is totally awful. There's no easy way to say this. And we are not wired to this either, but our team does a really, really good job at cleaning up this data in a way the manufacturers will buy and believe in our assessment. I'm going to move through some of this. I mentioned about the evidence and data, so I'm going to quickly go through this. These are the 2 main options, and I think Dr. Yee mentioned this in a slightly different terms, but this is the same concept. She mentioned financial MEA versus performance-based MEA, same concept here. And we can share a little bit more later on if you're interested in terms of which drugs or which entities we think about the financial MEAs, which is on the left side. So the drugs with established safety outcomes, which we pretty much know what the evidence is, we start here. We also start on the financial MEAs for things which are really hard to monitor or require subjective reporting of patient outcomes. So because again, they're really hard to defend sometimes, versus things like blood transfusion utilization, other metrics which are really objective. We try to go on the performance-based MEEs in a nutshell. The stakeholder input is really, really important. I was really impressed to see some of the work which you already have done on focus groups with meeting with different stakeholders. And I think this is the hardest part, is to make sure we start seeing that elephant in the room from different vantage points to ensure we are balancing the investment required for R&D, which is where pharma and a lot of advocacy groups are focusing on with access and cost. There's a quote in US by Thomas Edison: "The strategy without execution is just hallucination." I've come up with a new quote now, which is, "Powerful innovation without access is also just hallucination." And we need to remind ourselves to do that. That if we are coming up with the powerful innovations which are not accessible, shame on us. And we must try to work together as a society to convey that part. The measurement intricacies, this is really important part, so I'm going to spend a minute on here. So what are the outcome metrics? What are the consensus given recommended measures? And sometimes we do create the clinicians group, which is what we ended up doing with dementia drug coverage, to make sure we get input from them. And then obviously the data collection method, this is really, really important. We want to make sure we can get most of the data through existing methods such as prior authorization or claims data, rather than putting additional burdens on the provider community, which is already strained, as we all know. And then the durability of outcomes, and then ultimately deciding what the rebates should be. This is where the role of pharmacoeconomists comes into picture. Masa, who is our pharmacoeconomist, does a really, really good job at this to help us define this. And happy to share some of the intricacies associated with this. And then the power of analytics and data validation is also critically important. Here is our team. I would not go through this, but if you want to know more about it, happy to share more about this. Again, it's a very small team. Every other state which I speak with usually are spending a lot of time on the vendors compared to how our team is funded. Outcomes, the benefits and challenges, I pretty much kind of covered it for the most part. It does allow the manufacturers to kind of stand behind their promise. And it also provides us to make sure we are also spending our investment wisely than anywhere else. The challenges, as you heard from pretty much everybody else, operational realities, the data which comes in are not clean often. It takes a long time to do this. The delays in approval, we do get a lot of requests from parents and the providers saying, you're not doing this fast enough. And hopefully over time, we will do this faster than what we are doing right now. The program results, the manufacturers have been really, really happy for the most part with us. Boston, by the way, is also the mecca of biotech industry. So we also have a lot of great manufacturers. If you ever drive in Boston on the freeways, there are probably 6 biopharmaceutical companies on the left side of the freeway, which you will immediately see in a nutshell. So we also want to make sure we are being respectful and supporting the economy and the investment which we make in there as well. We currently have about 10 signed value-based contracts, and you see the 23 manufacturers on 65 drugs with a total supplemental rebates of about $400 million. The federal rebate, if you include that, the rebate amount goes to more than $1 billion out of about $4 billion on the pharmaceutical expenses in total. And then we are still working actively on probably about at least 4 additional contracts. So in summary, the innovations in pharmaceutical medications, which are really, really powerful, requires unique opportunities for us to improve care. And it will really require the heavy role of government in a balanced and thoughtful way. The outcome-based contracting offers one of the solutions. It does require a lot of operational and technological support to do that. And I think we are at the tipping point of doing so. And then the specialty medications, due to having very high costs, require newer levers for us to think through this. You heard about the Hep C challenges in Taiwan from Dr. Ko. These things are going to get more and more difficult as the amazing innovations continues to get faster and faster. Once again, I want to thank our pharmacy team, the HIRA team, and I also want to thank one more person who is sitting somewhere in the back, actually somewhere in the front here now, Dr. Shin, Dong-Soo Shin, who is the reason why I'm here, who we partner at the Hallam University through our medical school. Thank you all. Grateful to be here.
Thank you, Professor. 여러분 큰 박수 부탁드리겠습니다.
Please give him a big round of applause. Thank you very much for coming all the way to Seoul to give your presentation.
마지막 발표를 소개.
Now on to the last presentation of today. We're pleased to welcome Dr. Klaus Muldrup, Director of the Data Analytics Center at DKMA. He prepared a presentation on big data for better drugs. Dr. Muldrup has been working in the pharmaceutical field for over 25 years and currently leads the Data Analytics Center at the Danish Medicines Agency, where he oversees data-driven solutions to support public health initiatives. Please give him a big round of applause.
Director of Data Analytics Center of Danish Medicines Agency. 여러분 다시 한번 큰 박수 부탁드리겠습니다.
Another big round of applause, please, everyone.
Thank you so much for having me here today. I would like to thank the organizers of the HIRA committee and the leadership for inviting. It's actually a long-going relationship the Danish government has with Korea, so I'm happy to be a part of that as we move on, not only within healthcare, but within a lot of other areas. So that's important for us as a country to have this very strong relationship with you. So given the presentation, I think there was another slide before that. Can I go back? Yeah. So big data, better drugs. Well, it's of course a tagline, but I think this is what we all want to do. We want to make sure that we can get better drugs, both the drugs we have on the market and the drugs that are coming to the market. I've been working both as an academic, as a professor at Copenhagen University and INSEAD in Paris. I've also been a director at a big pharma company in the US, and now I'm with the regulatory bodies. So I know from all perspectives that this is actually what we want to achieve. So why is it so difficult? Could everyone ask? And that is, of course, some of the questions that we are trying to answer today with the presentations. So first of all, I would like to give a short introduction to how we are organized at the Data Analytics Center at the Danish Medicines Agency, and what we do and how we do it. I will give 2 examples, maybe even 3. One of them is not in the presentation, but I can explain it. It is a new project coming up. So with that, I will, of course, try to address some of the questions that you might also have in the audience. So first of all, the Danish Medicines Agency has 2 main focuses, actually 3. So we are giving, the registration of the medicine is on our table. We are also having all the controls with the pharmaceutical manufacturers. And then, of course, in the end, we are also the ones who are making sure that the medicines is available on the market. So we don't do any pricing negotiations, which is very important because these 2 things need to be separated, and I think the case is the same here in Korea. And we don't evaluate whether or not one drug is better than the other. But we do provide a lot of insights to those bodies who are actually taking that decision. So that's also important to have in mind, that we try to be neutral in our analysis and in our approach to what we do. So as you can see, we have these 3 centers. Of course, the Center for Organizational Services is more an internal thing. But then we have the Center for Control and Medical Device and Availability. So that is where we make sure that the medicines is available at a certain price, which has then been negotiated another place. And of course, we also make sure that we control the manufacturers so that they are also delivering at a certain quality level. Then we have also the licensing, so meaning that we are looking into all the applications, and of course the post-marketing surveillance, the pharmacovigilance stuff. And as you can see, the Data Analytics Center is reporting to the Director General, which is not anymore Lars Bo. He's left the building. We are getting a new one within a few months. But the reason that we report directly to the general manager is that we support any functions in the organization. And as you can see, here is what we call our working diamond. So our objective is always drugs or devices. We are only focusing on safety and effectiveness. And the data we're using is very similar to what we have been discussing all day. It's, of course, adverse drug reactions. It is electronic patient journals. It is real-world data registers, which we have a lot of in Denmark. One thing you should know about the Danish system is that any person has their own identification number and have had that for so many years, so that all data collected in healthcare is actually associated with that number, which means that if we have a side effect on a specific person ID, we can use that ID to see in any other of the healthcare databases if there is any comorbidities, other utilization of drugs, blood samples 20 years ago, whatever. So all that kind of data can then be put into the same association, the same person. And then we're also looking into social media data. I will touch a little upon that as well. And then, of course, the methods we are using is traditional pharmacoepidemiology, data science, it's large language models and AI, and of course some data mining. And results, again, our main focus is to produce some knowledge that can be used in a neutral, transparent way. So it's papers, it's reports, it's input for health technology assessments or health economic evaluation outcome research. And of course, we also produce algorithms. And these algorithms are then also public available. In the end, some of our stuff will be used for regulatory decision, and the products themselves could be even regulatory tools as one of the products that you will see later. So we are committed to utilize big data to generate insights and develop methods and tools that support the use of safe and effective medicines to all our stakeholders. Our biggest stakeholders is actually internal, our own organization, of course, because we provide data for organizational changes, regulatory changes, and EMEA as well, of course, as a European body. But then, of course, policymakers, providers, payers, our system, the ones who are negotiating prices, of course, pharma industry, and then in the end, patients. And you might say, well, patients should be the biggest one. Well, they are not our kind of main stakeholder. There are other peoples in organizations who are communicating directly with them based on our knowledge, of course. So we participate in a wide range of scientific groups. So big projects like READY, Ayyar, and Real for Rec, which are European projects. We are a main partner in the Darwin EU setup. And for the record, I've just been appointed a member of the body for Darwin EU. So I will hopefully have even more to say in that organization, which is good. At least I hope. And then, of course, I'll talk about a little later the FAIR project. So all in all, this ends up that we would like to utilize big data to provide better drugs. A little about our organizations. I will not bother you too much with that, but it's a matrix organization. So the yellow ones are our stars. They are the ones who are producing kind of the knowledge, so they are methodological experts. So they are all in charge of different parts of the projects that we are running. And then we are calling all the blue ones the guys who are bringing the water so that they can actually, the stars can really produce. So we are the bringing the water for them. So it's more across the board that we are supporting with project management, pharmaceutical governance, data management and funding and administration support. And of course, I'm taking the strategic management level here. So that's kind of how we do it. Let me just allude a little to you on the Darwin EU. It's already been said in one of the first presentations. And in essence, I had a meeting yesterday with other parts of Korean healthcare system, and I noticed that this is actually looking very much as what we do in Europe. So essentially what we try to do is, of course, to make a common data model. And we are also using OMOP as a common data model for the EU Darwin setup. The EU Darwin setup is a branch underneath the big vision of the European health data space. And this one is the first one really unfolding as we speak. So essentially, we collect a lot of data around the world, as you also do here in Korea, in different parts of the country, maybe in different formats. Then you need to harmonize them into a common data model, OMOP. I know you both use OMOP and another setup as well. And then, of course, we can compile some reports based on that, and which can lead to decision-making and hopefully then also change the regulations if it's needed, of course. So this is kind of the landscape at the moment. There is 30 partners at the moment. Denmark is one of the only one with a full data set on healthcare. So we are in charge of all the data, which have been all the different registers and so on. We have OMOP them because we had the same issue as you are seeing, that all the different regions and registers in the country had different kinds of data sets, but we have now OMOP those into a common data model, which also means that we are quite thoughtful when the EU is asking. So the process around this is that, let's say there is a country who experiences one or two maybe signals that could be a side effect, so they have some cases, then they can raise this as a signal, but they might not have a big enough population to actually see if this is true or not. And then the Darwin EU can be asked by the something called PRAC, which is kind of the body for pharmacovigilance in the EU, if we can run a study on this specific issue. And then we will receive a script, and that script is then run on our data, which means that we can then produce a report, send it back to the Darwin EU, who can then report and compile a full report of all the partnerships or partners who have engaged in this study, and then report directly to the pharmacovigilance organization that is then maybe making a decision of a regulatory scope. The reason we do it like that is that, of course, one of the biggest issues, and you all have experienced that as well when we talk about data, is that we are seeing a huge issue around privacy. So all data are kept in each country. So the data from the Danish registers will never enter another state in the EU. So that's why we are receiving a script, running that script, delivering the data in an aggregated level. So, and that is happening for all of the countries. In that way, we are keeping the data in the country, and we are also obliged to, of course, following all the GDPR and privacy rules. It actually took us more than 5 years to get access to these data, even though we are an official body in the Danish government. But that's just how it works. And still we see some problems in some areas now in one of our research projects where we want to get access to some data, which is there and has been there for like 30 years, but where the there's never been a formal consent from the patients who have delivered the data. And this is why we cannot then use the data, which is, of course, unfortunate, even though a lot of the patients would just like to give it to us. Let's give me an example. Pharmacovigilance, some of you know this area in and out, but just a very brief introduction to pharmacovigilance. Of course, there is some reporting actors. It could be either healthcare professionals, it could be patients themselves, so laymen, it could be the market holder, or it could be researchers who is then saying, okay, there is this a side effect. It could be either spontaneous, so something just popping up at a consultation, whatever, but it could be also in the periodic updates from the manufacturer or even in studies running. And then we as a body, so the Danish Medicine Agency, even the European Medicine Agency and WHO Monitoring Center will then be informed. Maybe they think this is an important signal, and then they will ask for further studies in order to maybe again do an implementation of a change in, it could be the drug SPC or something like that. That is a very long process, and some of the biggest issue with that is that usually there is actually two things. It takes long, but there's also under report in side effects. It's well known from any studies that there's a lot of side effects out there which never reaches our mind or even the doctor's mind. So can we in any way accelerate this process using AI and real-world data? That was kind of the idea with the next project, which is in pharmacovigilance in the future. It's called FAIR, Pharmacovigilance by AI Real-Time Analysis. So today, we have a lot of data. So let's imagine that we get a spontaneous report at the Danish Medicines Agency for a side effect. It could be from a citizen. So we have not seen any other reports. This is the first one. And today we have to wait until there may be another report in a half a year, or maybe a new report again in a year, and so on, and time goes on. And in the meantime, a lot of patients might even be exposed to that side effect, but we are not able to react on it because we don't know it. And it's not big enough yet to do something important about it. So let's imagine that we take this response from a certain patient, and then we take that response and we then use our registers, because it's the same identification number of the individual. We enrich the data with all their other healthcare data, so visits at the hospital, visits at the GP, their blood samples, comorbidities, disease history, all of that stuff, we enrich that. We even enrich it with the unstructured data from the medical journals, where we can then use the meta terms to kind of extract the data and say, okay, they are actually talking about something which is a side effect, but it has never been reported. If we do that and then mirror that person against the full population that are like that person and see if there's other cases out there which has just not been reported, then suddenly we can enrich the data from one person maybe to 5 persons at day one. And then that might be enough. We can then go back, of course, to those new 4 persons coming in which have never reported the side effect and ask if this was actually a side effect, if they did experience it, but it was never reported by the doctor. Suddenly we have 5 cases, and those 5 cases are then enough to raise a signal, which of course is a lot faster than waiting. So that's kind of the idea. We are doing the validation right now, so we're doing this from now on and the next year. And our idea is, of course, to produce what we call a minimal viable product, which is then doing this on the side of our traditional setup. So, of course, we will not let AI do this by itself right now, but hopefully, and that's, of course, the intention. One more thing here. We, of course, need to then do it manually to see if there is any other validation points that we need to go into. But then the final product, which will be then in 3 years, will be a product that can do this automatically. Even searching into social media data for unstructured meta terms, we know that a lot of patients might discuss this with their peers in social media groups, but never discuss this with their doctor because they might be embarrassed or whatever about it. And then we hope to see the first PRAC process, which means, again, the European Authority for the Pharmacovigilance Reporting, in 2028. And if this is working out the right way, in 2029, we might see the first fully AI-based regulatory intervention based on this setup. Because, of course, we need to make sure that it's validated and okay, but of course, this could be a very interesting approach and see where we're going with this. So that is one example of how we're working with it. So the case that I have not put in here, but I just came across while I was listening to some of the other speakers, is that one of the things that we are going to initiate now, or actually just a footnote to this could also be used for conditional approving, which means that in those cases where we give acceptance to a product with less material than usually needed, this could also support that process after it's kind of released to a conditional population. So that's also one of the scopes with this FAIR AI-based project. But the other project I would like to allude to you is that for several years, of course, personalized medicine has been kind of a hot topic, especially within all the most expensive medicines. The reason for that is, of course, that the manufacturers want to produce a new, interesting medicine for maybe a smaller population, which means it also becomes more expensive because all the cost to produce it and so on. So the business case is clear from a manufacturer's point of view that, of course, we want to have a bottom-up process with R&D leading to a product that maybe is only suitable for a very small and limited part of the population, but is very targeted towards that specific patient. We are now initiating, I would say, a top-down process, because we believe that there is so many drugs out there which is already very good. But one of the reasons that they might not be as effective as we want them to be is that they are used in a one-size-fits-all manner. So as an example, and I think it counts for your country as well, when a drug is then evaluated and it becomes first choice, then nearly everyone needs that drug for a certain condition as the first choice, due to, of course, the evaluation of its effects, but also due to the cost in some cases. So that is very common. But of course, one of the risks with that is that some of the patients getting that medicine is not suited for that medicine. They might have side effects or even don't have an effect. And in some cases, then they get a new drug, so the second drug in line. And they might even have side effects and loss of effect for that drug. And then they get the third drug in line and fourth drug in line. And suddenly, after 2-3 years, they are on the drug that they need, hopefully. That is a kind of a guinea pig approach to get the best effect of the medicine. What we are trying to do now is say, okay, is there any characteristics of those patients who are in the journey from maybe the first drug to second drug, those who are then ending on the second drug? What is the characteristics if we take the big data of those patients? And what is the characteristics of those who get the third, fourth, and fifth drug? Could those characteristics, based on the big data from the full healthcare picture, all the comorbidities and so on, even in some cases there are phenotype, genotype, if we have that kind of data, could all that maybe lead up to that we choose the right medicine for the right patient in the beginning? So instead of just having a one-size-fits-all approach due to price and then a general effect of a population, could we then say, okay, with your characteristic, we know that in this percentage of cases, you will have a better effect of starting on drug number 3. There is a huge price reduction on the full kind of journey with the medicine. So you don't need to see your doctor because the medicine works. You don't need to use some medicine which doesn't have any effect anyway. So you could really calculate a healthcare outcome by doing this. And we are able to do it, and we will be running this study within the statins as an example first. So we are not only talking about the expensive medicine here, we're actually talking about the more common used medicine where there is a lot of people getting it, but they also experience problems around the medication. So that's another way of using big data and real-world evidence, real-world data, and turn it into evidence that we can actually recommend which characteristic or persons that needs which drug at a certain point in their, so that they skip this kind of guinea pig approach. So we are at that level now with our data, which I'm looking very much forward to. Yeah, I'll just skip this because I already told you about the control cases and so on. So yeah, that's actually it for me. If you want to get in touch, you can find me on LinkedIn, and I will be happy to connect and also to discuss in this panel. And once again, thank you to HIRA for inviting me and the Danish Medicines Agency to present at this very important symposium. Thank you.
Thank you.
Thank you. Thank you for your presentation, Dr. Modra. So that was the final presentation of the day. We will now move on to panel discussion. So let's recap the topic of the day. So we had an event themed around the evaluation of high-cost drugs based on RWD. As our president of HIRA mentioned in his speech, innovative drugs and technologies are on the rise, and with that, evaluation on the effectiveness and economic viability is very important. The discussions and presentations that we had today will contribute to the advancements of healthcare insurance and also systems. The first presentation was done by Professor Dave. He talked about insurance application for drugs and also balanced approach. We'll hear more from him during the panel. And the final presentation of session 2 was done by Dr. Modra. He talked about big data and better drugs. Now let's move right on to the panel discussion. We have Mr. Jung Lee, Chair of Pharmaceutical Benefits Assessment Committee of HIRA. Let's welcome him with a big round of applause. Thank you. Panelists, please move on to the stage. Ms. Unju Lee, Deputy Director of Pharmaceutical Benefits Division of Ministry of Health and Welfare, please come onto the stage. Mr. Dong-ho Yeo, Head of Market Access LG Chemical, Korea Pharmaceutical and Biopharma Manufacturer Association. Mr. Jun-Soo Kim, Market Access Director of AbbVie, Korean Research-Based Pharma Industry Association. Dr. Kasia Licker, Manager of Strategic Pharmacy Contracting of Mass Health. Dr. Modra, Director of Data Analytics Center of Danish Medicines Agency. Everyone, please come onto the stage. And this is the last panel discussion of the day. Let's welcome them with a big round of applause. Thank you for staying with us until the very last section of the day. Thank you so much for joining us today, everyone. We will hear brief presentations from our panelists who have not presented. So Ms. Unju Lee, Deputy Director of Pharmaceutical Benefits Division of Ministry of Health and Welfare. So I will introduce each and every panelist.
Hello, I am the Deputy Director of Pharmaceutical Benefits Division of Ministry of Health and Welfare. I'm in charge of reimbursement listing for new medication. Right now, all around the world, right now the presenters have given us ways that each country is using RWD and RWE, and I've gotten much insight. Korea is also trying to utilize RWD and RWE for RDD reimbursement as well as digital therapeutics reimbursement, and we are making a lot of diverse efforts. RWE that can complement the shortfalls of RCT and additional measures to improve decision-making are very important. And recently in high-cost drugs, we have already started evaluations utilizing RWD and RWE. So for medical assessment, especially HTA, I think that Korea can benchmark upon a lot of the details and agendas that we heard from the presentation. Also, the last speaker, Mr. Klaus Muldrup, talked about ways that we can utilize AI. And I think that if we utilize what he just mentioned, we all can benefit. So I hope that more of you can share additional information with the Korean government, and I hope that we can continue to collaborate going forward. Right now, when it comes to the information asymmetry between manufacturers as well as payers, it's a quite serious problem that our division also needs to tackle. So if you have a lot of experience regarding this, I think that we can gain insight from your words. And also the Korean government will continue to make effort in making high-cost drugs available for patients utilizing RWD. If you have any additional... Also, I have a question. For both countries, for both of the presenters, I wonder whether there were any conflicts of interest in negotiating a lot of the process that you mentioned today. And I wanted to ask this because I felt like the Korean government could also make use of your insight. Once again, I'd like to thank the presenters for your presentations today.
Sorry about that. Thank you so much. So we'll go through all panelists for their comments, and we'll get questions right after all the remarks are done. So going on to the next panelist, Mr. Dong-ho Yeo from LG Chem, please. Hello, everyone. Thank you so much for inviting me as a representative of the Korea Pharmaceutical and Biopharma Manufacturers Association. So I represent the industry and corporation side in this discussion. I think it's very important to reach an agreement among stakeholders. And the most important stakeholder from corporate standpoint would be businesses, corporations, the companies, because we manufacture and produce and get approval for drugs. And pharmaceutical companies in that regard are very important and need to be part of the discussion. So I think gathering like this will be an important starting point for further progress down the road. So I represent the Korea Pharmaceutical and Biopharma Manufacturers Association. Performance valuation of high-cost drugs based on RWD. I really wish that there were high-priced drugs. And I think it would be great if we could consider and contemplate the possible contribution of RWD in evaluating high-cost drugs, but I don't think we're there yet. However, I think we are here to discuss the topic because we wish to develop such high-cost drugs. And if you look at the world, look around the world, there are extremely high-cost drugs, especially for rare diseases. And we sometimes import them to provide access to patients in Korea. And we will be part of that. But during the process, the challenge that we face is that most of the times, these new and innovative drugs lack evidence. And when we go through reimbursement approval process for those drugs, there are a lot of hurdles, especially because of the lack of the evidence. And then the response we oftentimes get from the regulatory body is that it's not going to work. Then the question is, when we introduce the necessary drugs in need and we evaluate the performance, I think the processes are in place and we appreciate that. But during the processes, I think we need more proactive work, which means that we get a lot of feedback during the process. But a lot of the data needs to be standardized. Still, a lot of the data is very heterogeneous. And also, if the process can be faster, if we can get faster access to those drugs, it will be a lot easier for us to start a conversation with HIRA and other regulatory bodies. And also, I think we need to achieve harmony among relevant bodies. We often work with HIRA and Ministry of Food and Drug of Korea when it comes to approval and reimbursement. And these two bodies have sometimes conflicting guidelines. And it will be great if, from company's standpoint, if the guidelines can be more harmonized. For example, the guidelines that we considered during approval process, if that can also be applied during reimbursement process, it would be a lot easier. And even through the post-market evaluation process. Also, domestic companies oftentimes lack resources. So, if possible, since we're having all of these discussions here, it will be great to have a more detailed and complex set of guidelines. And with that, we will be able to have a better understanding of the process and work with the stakeholders to get approval and get reimbursement. So I think KIP will have a better time of commenting on other topics, so I'll wrap my remarks up here. Thank you.
Thank you very much for your valuable perspective and insight regarding standardization of data, interdepartmental and interagency cooperation, as well as presenting detailed or announcing detailed guidelines in advance.
다음 패널은
So the next panel list is Mr. Kim Jun-soo from the Market Access Director of, who is the Market Access Director of AbbVie, as well as Korea Research-Based Pharma Industry Association. Thank you very much for inviting me, and I'd also like to thank HIRA. So the pharmaceutical industry doesn't oppose the use of RWD, but we're wondering how we can utilize it.
오늘 제가 여러 연자
So today we heard from many presenters, and I was very happy to see that our perspectives are aligned. So basically, we're all focusing on the limitations, the benefits of RWD, and how we can advance forward. So Mr. Dave talked about the word balance, and that really struck a chord with me because it's important to manage drug prices, and it's important to make sure that medicines can enter the market in the first place. So what I do is I always get challenged, and I try to make effective medicine enter the Korean market. And Ms. Lee talked about fair pricing in the morning. So if we consider fair pricing in the future, I think that Korea is doing a very good job. When we consider countries with higher GDPs and lower GDPs, Korea is doing very well in terms of fair pricing. So HIRA, as well as all of the other stakeholders, are really making great effort to make sure that innovative drugs in Korea are well priced. So within each country's regulation, it's important for us to find a balance and to conduct or push forth adequate policies. In Korea, we have relatively low-priced drugs, and I think outcome-based risk sharing is a good option for Korea. And also, we had a demonstration project in HIRA where we compared the results of RWD as well as RCT. And the results showed that there wasn't a big gap. And physicians that participated in the demonstration project talked about how RWD could be used to provide guidelines to patients. Also, when we try to utilize RWD, it would be important to realize where uncertainties of drugs are to complement for the shortfalls there. Now, in the US, outcome-based contracting uses RWD, and that is the new trend, which is what the presenter mentioned. Outcome-based RSA in Korea, I think, could utilize RWD as well in that respect. Also, we heard about 2 specific cases in the morning from Director General Lee, and I think that we could also create indirect comparing guidelines to supplement for the cases. And also, we should include, I don't think we should include all high-priced drugs, high-cost drug when it comes to utilizing RWD. I think utilizing national level registry is good, and I think that we can make use of the claims data that HIRA has, as well as medical institutions data that will lead to the highest quality of drugs. And regarding interagency collaboration, I think RMP data of the Ministry of Food and Drug Safety, as well as HIRA's registry, shouldn't be separate. I think all countries out there want to create RWE and RWD registries. Some countries might be able to utilize some registries from other countries, and these registries all need to be valid. In the case of Korea, we have separate registries for the Ministry of Food and Drug Safety and HIRA, and it's difficult for us to gain access to overseas data. So I think that we need to think about this. And also, regarding Canada, we talked about robust methodology to develop guidance and extensive stakeholder engagement and feedback to shape the guidance. So that is what presenter Klaus Muldrop mentioned. I agree 100% with these 3 points, and I think that we need a guideline and we need to set the target range, and in data collection and production, we need to think of how to decrease uncertainties and to decrease side effects. For this, I think creating working groups would be the best method. In creating data, it's important to include the key stakeholders, which would be us, of course. Thank you very much.
네, 감사합니다.
Thank you so much. That's the reality of Korea. All the rare disease drugs are imported. So Mr. Kim shared how real-world data should be utilized from Korea Research-Based Pharma Industry Association's standpoint. I think it's encouraging that he welcomes the use of RWE. Data analytics and standardization of the format, and I think that they are willing to welcome the trend as well. Next, we have Dr. Neha Karshalikar from UMass Health. I think she's from the same institution from Dr. Dave.
Additional comment is still you are the key person to have a value practice based contract in mass. So
yes,
I think it's your real time, practical experience might be very helpful for us. Please.
Certainly. Thank you so much for that question, and thank you to the HIRA organization for having me here today. It's been such a wonderful day of learning from other leaders around the world and how they've been able to both gather and garner real-world evidence and have application of it. From my perspective and from our organization's perspective, real-world evidence is critical to being able to develop and implement value-based contracts. So as you learned a little bit about from Dr. Dave, our program currently has 10 value-based contracts in place, and our team works diligently to develop customized monitoring programs based on real-world evidence to be able to actually implement those contracts, collect the data, and garner rebate for the Commonwealth. I'm really happy to be here today. I'm happy to answer any additional, more specific questions that you all may have for me.
Thank you. Thank you very much. Panel's discussion, do you have anything to add on or any more comment, please?
Yeah, actually, I think I have one, and I think we tend to make it more difficult than it actually is. I think and I have one practical example also, but just to take a responsibility focus here is that if you're a patient who wants a specific medicine for a specific disease, and if you're a doctor who really wants to prescribe this medicine, even though it's very expensive, we could make it mandatory that they follow specific programs for patient-reported outcome measures. In fact, I think that each patient in the world, each patient getting whatever medicine, should actually be reporting patient-reported outcome data in order to get the next prescription. In that way, we will get real effective and nice data. And of course, what's difficult in the negotiations around value-based pricing is that what are then the outcome measures that needs to put in place, and what should be the price and the consequences if the company doesn't meet it. The anecdotal note I would like to address here is that in 2004, I think I made one of the first value-based pricing approaches globally together with the company Novartis on their, at that point, Diovan drug for heart or blood pressure. What we did was, and I developed that campaign, and it's actually reported in the British Medical Journal. What we did was that the company assured that if the patient who got the medicine didn't reach goal, which at this point was 140/90 in blood pressure, then the patient would and the government would get their money back within 3 months. So the funny thing here was that, of course, a lot of patients didn't meet that goal, but they actually forgot to reclaim their money because it was so small money. And those who actually then wanted to reclaim it, they of course got their money, and then we wanted to pay back the government, but the government was actually not ready to get the money back, so that was quite a big challenge. But it can easily be done, because in this case it was actually just reporting on blood pressure by the patient and the doctor, and then they could reclaim. So there was something in it for everyone, and I think that's maybe the most important part. There should be something in it for the patients themselves as well. If they don't report on the real world, on the patient-reported outcome, they will not be able to get the next prescription. As simple as it is.
Thank you very much. Well, 그러면
All right, then. Thank you for your comment. Let's get questions from the floor. Hello. I'm Jo Soo-jin from Hanlin Medical School. I saw 50 patients this morning, and I ran to join the symposium today. Thank you for arranging such wonderful symposium, HIRA. So back then, I have an experience where CGRP was introduced to Korea, and after 1 year of introduction, some patients told me that the drug changed their lives. But then after 1 year, it was out of reimbursement, so many patients were worried about the price. So what I wanted to ask is that when we say stakeholders, pharmaceutical companies are stakeholders, but doctors and patients are stakeholders as well. So when you analyze RWE and RWD, when it comes to negotiations and when it comes to reaching an agreement, I think doctors should be involved as well. No matter how good the drug is, doctors are the ones who recommend or introduce a specific drug to patients. Sometimes I look at my patients, and then sometimes I think, maybe my patients are exposed to less drugs or something. It really depends on the preference or inclination of the doctor. If the doctor doesn't want to prescribe a lot of drugs, then the patients will not get a lot of drugs. So doctors and patients, I think they should be involved as stakeholders in the negotiation and agreement process. And also, I agree with all the comments and remarks by the panelists. I hope that we will have more and better drugs in Korea so the patients can benefit from them. Thank you. It was more of a comment than a question, but thank you so much.
Hello, I'm from NHIS. I am Min Bo-kyung. I manage pharmaceutical benefits. So we have the Director General here from our team, and as well as a lot of team members that are here with us online. I wanted to actually ask this question in the morning to Director General Lee. I learned a lot from her keynote speech, especially the Kymriah case. I think that a lot of you from HIRA as well as NHIS would have learned a lot from that case. Performance-based RSA is being implemented in Korea, and I want to ask how we can go forward with the Kymriah case, I want to ask this to our Director General Lee of HIRA or other HIRA affiliates. And also, Dr. Bor-Sheng mentioned how in Taiwan, from the second year, the reimbursement for GC was stopped. And I think that once reimbursement, once treatment has been listed in reimbursement, it's very difficult to get that off the list. So he mentioned that case with liver cancer, and I wonder how that was possible. And I wonder from other countries, if other countries also have similar cases in getting some drugs off the reimbursement. Okay, so who's going to give the answer? So the main gist of the question was regarding exit and dropout. And we heard from Taiwan about the data of ICI, how for certain types of cancer that medication was dropped out, how ICI was dropped out for certain types of cancer, like liver cancer. But to answer from HIRA's point of view, I don't think we have experience in seeing enough data of the same kind. But I think going forward, that might be applicable for Korea. And if we have value-based contract in Korea, then I think exit would be included as well in Korea's case, also going forward. And when we heard from the presenter from Boston, Mass Health, I remember something about indications, how indications might expand, but it could also drop out regarding the value-based contract. Now, that was very insightful for me. So I gave the reply. I'm not sure if this was enough. If you feel like my reply wasn't enough, please ask for a better detailed answer after the symposium is over. Does anybody have any further questions?
Yes, and I can just add a little bit of additional if that might be helpful. Perspective in our experiences. So being a state Medicaid program, we are mandated to cover all products that are approved by the FDA and enrolled in the MDRP. With that said, there are certain non-mandatory benefits that value-based contracting has afforded us the ability to be able to cover, and those contracts seem to have a double protection in that, one, it provides protection to the state on the costs, and two, it allows us an ability to actually assess real-world outcomes on those products and then make the determination if there is continued value in offering the non-mandatory benefit. So hopefully that response is also helpful in terms of how some of the decisions may be made to draw back coverage if that's necessary.
Additional comments or questions from, yeah, Dr. Lee, please.
아니 이소영 박사님이 아니고 이진수입니다. JS 리가 비슷해가지고요.
Okay, so I'm also from HIRA. I'm in charge of assessment of treatments, and I assess the feasibility of treatments, so therapies, but to increase access to medication, exempting PE is often used. And when that is the case, HIRA utilizes pre-assessment process. And in this case, real-world data is used. Now, what Director General Lee mentioned about Spinraza is what I want to talk about. For type 1, it was effective, but after a patient became an adult, so after it became type 2 to type 3, there was already damage and it was not effective. So in terms of Canada, First of all, they reimbursed all cases, but then they limited reimbursement based on this data. In Korea, we wanted to create a similar case, but all of the patients and pharmaceutical companies and doctors' perspectives and standpoints, we cannot do the same thing that Canada did. So, in actual clinical practice, I mean, of course, increasing access is important, but I think it's also important to utilize budget because it is limited, right? I think utilizing real-world data to decrease coverage or reimbursement could be one case that I would be interested to hear about.
Anybody answer?
Could you just repeat the question? Sorry, the question one more time. I just hear it.
So
I think it's really important to be able to take both confirmatory trial data and real-world evidence into consideration. There are certainly situations where we can rely strictly on the confirmatory trials, but to reference Dr. Dave's presentation, there are more and more products being approved through accelerated approval pathways based off of surrogate endpoints, where we don't necessarily have that clear causation between the biomarker endpoint being measured in confirmatory trials and true clinical benefit. So in those scenarios, there definitely is a role and a necessity to be able to evaluate real-world evidence to build upon what the baseline data may be and make a determination as to whether that should impact coverage or the appropriate outcomes for outcomes-based assessments or contracting. I think relying purely on confirmatory trial or clinical trial data limits us in our ability to measure true clinical benefit.
Any further questions from anyone? Yes, please. Thank you. In Spinraja experiment, it was not actually done in adults. For type 1, it was done in children, so we need to give an opportunity to experiment it against adults. In type 2 and 3, damage is done, but then in clinical trials, because of the regulation that they continue if it doesn't get worse, so it's not helping. So real-world data is not helping, so reimbursement is not working. So in Korea's specific context, we are not in charge of the regulation, so we are actually being victim to the regulation. So on the national level, I think we need to reconsider the policy. We need to stop prescribing to patients who do not need it anymore, and then we need to prescribe more to the patients who need it more. Thank you. I think Dr. Lee gave a real-world example of a pitfall that's happening in Korea. So the condition, the entry condition, needs to be defined based on the outcome. So we need that. So for patients 5 older or above, we need to give opportunities to them as well. So there's no such data as you saw. So it was not evidence-based, it was not policy-based, it was just sentiment-based. So we need to make sure that such pitfall doesn't happen again, and it needs to be prevented in the future. So that's how we need to prepare for future cases like that.
Questions for Dr. Mechnikar, because since you are the right person who have all this value-based contract, how did you get all these stakeholders get involved, agreed upon this value-based contract? Because especially the manufacturer among the stakeholders, they don't really have any merit. And the second is for the operational, following the old after contract, to have all this data collect, analyzed, and all this or not, it costs money and time. Who is paying for?
Thank you for your questions. Yes, I am happy to speak to the first question to start, which was in regards to the stakeholder involvement. So I think that we are fortunate to have a tool that many others may not have access to. So Dr. Jatin did mention that we have a unique authority that was granted to us in our state authority to directly negotiate with manufacturers, and that's three-part. So the first part is just the ability to enter into negotiations. The second part is the ability to develop target prices and put them through a public process. And that provides us just in and of itself a unique tool to be able to garner public attention around a particular drug based on evidence-based medicine and the outcomes that we're seeing, and set a target price that we feel is fair and is then reflected upon by the public. And then the last element of the authority that I think provides us the most muscle to be able to bring movement to the table is our ability to theoretically refer a product to the State Health Policy Commission, which is an unbiased organization that would then do an independent assessment of the product and determine if it has fair pricing. And I think that has allowed us to potentially move more conversations that, perhaps there was originally some reluctance from the manufacturer's perspective in approaching the table and getting involved in a value-based contract. But having that additional leverage allows us to potentially bring them back to the table. So that's, I don't think, the entire story. I think we also have had excellent partners in industry. And I think that the two pillars of our program that Jatin spoke to, which is a data-driven approach and relying on evidence-based medicine, has also allowed us to cultivate relationships with industry so that they understand that we're taking a very transparent approach with them, that we're trying to rely on what we think would be best practice, and we're step by step very clear in the rationale as to why we select an endpoint, how we calculate a rebate, and it is not for any type of undue profit or to put them in an unfair position, but just what we think is appropriate based on the literature and consensus guidance that's out there. So that's the first part of your question. And then in terms of operationalizing the contracts, all of you were able to see the great team that we have supporting that work. But I will also say that it is no one person's entire job working on this initiative. So everyone has other responsibilities, and that's where some of the ability to be able to implement this without a significant increase in cost to the Commonwealth is able to come into place. So when we think about operationalizing a contract, wherever possible, we rely on resources that are already available to us, looking at claims resources such as medical or pharmacy claims data as the outcomes that we should be tracking. Additionally, we already had a robust DUR program that managed all of these clinical guidelines and had clinical experts that we could rely on when creating monitoring programs. And so we tapped back into that resource to be able to develop customized monitoring programs for each of our value-based contracts. And finally, in terms of claims processing and invoicing, those teams already existed, and they were wonderful to work with and flexible and able to create a new process that the same team implements, which made it possible for us.
Thank you very much. One last question to Dr. Moldorov. You mentioned about the Darwin and the common data modules. Do you have any common data module for each disease or specific drugs? You cannot use all the generalized one single form for the whole medicine and the whole kind of drug, right?
Yes.
How do you develop the common data model?
Yes, so the common data model was developed by the EU Darwin project, and then it has been we need to adopt into it, and it is across all the diseases, all the products. So it is actually covering all. It is a quite big undertaking to make sure that you actually have the right data in there. But actually, if I may, just a comment back. So you're doing all this great work with these pricing mechanisms and so on. Of course, in the interest of those companies who have a, let's say in your risk district, there is a lot of patients, so for them the incentive to do more, maybe even lower the price a little more, and do some more studies and so on is of course bigger than if it's a more, let's say, a smaller country where they don't have the same incentive because of the population eligible for the drug. To what extent would the job you're doing actually be, you could call it open source, so that could be the data coming out of it, even the kind of the contracting settings and so on, could even be used in other maybe smaller countries so that everyone can get access to the drugs?
Yes, I think that's a great question, a great consideration. I think taking the approach in situations where perhaps you don't have as many patients and perhaps there isn't as much buy-in from manufacturers to come to the table. One option is to present it as an opportunity for data gathering for the manufacturer as well. And I mean, especially in these limited populations where there may be an orphan designation, there's not a huge patient population. Payers have the perspective of being able to track outcomes that may not readily be available to manufacturers, and in a way and with real-time outcomes that certainly are not available broader. So I think that could be one avenue to be able to bring someone to the table and just say, this could be a partnership. It's not us telling you, you have to do this. It's a negotiation and a partnership.
Any more comments or questions from the floor? Well, thank you all the panelists to sharing your valuable experience and expertise with us from the last session. Thank you again. We'll close this session now. Okay, thank you very much.
네, 고맙습니다. 큰 박수 부탁드리겠습니다.
Thank you very much. Please give them a big round of applause. Thank you very much for staying with us until the very end. So today we had valuable time sharing insights and exploring future directions. And we had a very long day, but we had fruitful discussions. And I believe that today served an opportunity to discuss about the future healthcare system. I'd like to once again thank HIRA for providing this meaningful platform, as well as to all of our participants who joined us today. So before we wrap up, we'd like to mention that we are conducting a satisfaction survey. So please use the QR codes and fill out the survey so that we can meet you once again later on. Thank you very much for staying with us and for such long hours, as well as to all of our online participants. And with this, we will wrap up the 2024 HIRA International Symposium. See you next year. Thank you very much.
네, 잠시 안내드리